Casey, can you hear me? I cannot hear y'all.
He
I can hear you now. Perfect.
okay.
We had us on mute because we are still streaming.
Oh, I see. Okay.
We're almost at 10, so let's
Yeah,
just go.
yeah.
If everybody's ready.
Obviously, we're unmuted when you stop to share.
Perfect.
We're about to get started if that's okay with you, Dr. Kirsch.
Yes, I'm ready. I'm ready when y'all are. You just let me know.
So,
Wait to let the public comment before.
yeah, you want me to wait and do it, or you want?
I think he's DDS.
Yeah.
Two.
Okay, yeah, let's wait and let them in right before we get to the other part, just so that in case they're
So
not.
that person's online.
Excellent. All right, whenever you all are ready.
Do we have everybody on? I didn't see Dr. Burke. I didn't see Miss Palermo.
Yes.
Oh, they're okay.
There she is.
Oh, I see everybody now. Okay, perfect. Okay. All right. The March 11th, 2021 licensing committee meeting of the Texas State Board of Dental Examiners will now come to order. The time is 9:59. If you're listening to the meeting on a secondary device, such as a computer or tablet, please mute it until it's your turn to speak. Please say your name before your verbal vote during the voting process to ensure a proper count. And I will announce the names of board members when addressing them by the first and on their first and second motion. I would like to read our mission statement. The mission of the Texas State Dental Board of Examiners is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. And Ms. Nichols, can you do the roll call for us, please?
Yes, sir. Dr. George Kirsch,
Present.
Miss Lois Palermo. I saw her. I
She's
see
on
her.
there. Yeah, she's on there. Unmute.
Yes, I'm trying to unmute myself. Present.
Dr. Margot Melcher.
She informed me she would not be here. She texted me yesterday and she excused herself from the meeting.
Yes, sir. Dr. Linda Burke.
Present.
Dr. David Tillman
Here.
and Miss Catherine Sisk.
Here.
Thank you. Dr. Kirsch, we have a quorum.
Perfect. All right. Our next issue would be pertaining to the proposed rule 101.2 and 103.2 of life patients. I know the TDA has had numerous concerns with dental students as far as finding patients for the exam coming up in April, and they believe they want some clarification as far as if students don't have a live patient and do it on a simulator, will the Texas State Board accept their license? And I think we need clarification on this rule. First of all, the rule has not passed. It's just sitting on the governor's desk, and we're waiting to hear for approval from them. So the rule is what the rule is right now. So we're accepting whatever students take. So I want to say that just to ease everybody's mind. And if by chance the governor does approve the live patients, we're not going to retroact it. If you've taken the exam under the previous rule, you're going to be accepted as a licensee in the state of Texas. So I would like to turn it over to Ms. Studdard. I hope I didn't steal any of your thunder, Lauren.
Dr. Kirsch, you summarized it. What I was going to say, at this point, the rules haven't been approved yet pertaining to the live patient examinations, the rules that were discussed at the September 2020 board meeting. But if we do hear back, we will let the board members know, and the rules will be published in the Texas Register for public comment.
Is there any way that the board can reach out and let TDA, let students taking the exams in April know that right now nothing? Yes, Ms. Nichols.
We have updated our website, and we also sent an update to all of our examination all deans and Reb and everybody else to let them know that we will still be continuing to accept the simulation and mannequin-based examinations.
Perfect,
To appease the minds of their students and our future licensees.
perfect, great. Thank you, thank you. So I don't believe this needs a vote or anything, right? Okay. All right, next on the agenda is possible action on dental public health specialty. We've had numerous concerns by dentists and other people in the community. There are a lot of dentists getting their license to practice dentistry in Texas without have gone to a CODA accredited school. So these are foreign students who are coming in doing public health residencies, not seeing a patient, not doing injections, and yet getting a license. Is there any way we can amend that rule to prevent that from happening? And I'll turn it over again to Ms. Nichols on this one.
Yes, thank you, Dr. Keir. So stakeholders, like you said, have voiced concerns that practitioners who graduate from these programs don't have the necessary clinical training. So many of them may not have actually seen patients. So those applicants are required to have completed 2 years before we would accept the dental public health specialty, and they have to take a bunch of courses prior to that specialty course. Ultimately, it's our understanding that this meets CODA's requirements, so we've been approving them. But board staff would be happy to take a look at Rule 119.1. That has our list of specialties that we do approve. The pushback that we might get is that we don't actually issue specialty licenses. So you're either all in or all out. You either get the so. But board staff would be happy. Like you said, we've gotten some concerned stakeholders reaching out to us. We'd be happy to take a look at 119 and see what we can do.
Perfect.
Present some options to you all.
Will y'all do that and present that to the next licensing committee meeting? Okay, perfect, great. Thank y'all very much. All right, next is possible action request for exemption from board rule for DDS 1. I believe he is, Dr. Tillman, yes, sir.
Comment, if staff could also kind of review liability concerns, if there are any, to going kind of separate route from what CODA has recommended. We had a concern obviously previously through the implants society and as far as recognition of specialties, and if that does open the state up to liability concerns, I'd just like to know about it. If they could just kind of review that related to the previous topic. Thank you.
Will do.
Thank you. And this next one is DDS 1, exception to board rule. I believe he has taken his application off the board. Is that correct? Because he doesn't have all the information that he wants. So,
Yes,
Ms. Studdard? Yeah.
this applicant withdrew his request, so the committee does not have to consider this agenda item.
Perfect. All right. Next on the agenda will be, again, action request for exception to board rule, DDS 2. And I believe she was trained at USC, passed all her boards, but she's never held a license in the United States. It's only been in Canada. And per rule 101.3 A2, you must have had a license in good standings in one of the states or Providence. I believe it's British Columbia. But Ms. Studdard, I'll turn it over to you.
Yes, that's correct, Dr. Keir. So board staff is deferring this applicant to the committee for review. The applicant is applying for licensure by credentials. However, she does not meet the requirements of board rule 101.3A2 due to not practicing in another state, District of Columbia, or a territory of the United States. She is licensed in Canada and has been since 2014, and she has passed her regional clinical exam in April of 2014. And she is on the line to submit a public comment for y'all.
Okay, can we hear from her?
Yes.
She on?
still joining.
Yes, we have her. Dr. Kirsch, she's connecting still.
Yeah, it's
Okay.
waiting for our audio to.
Now she should be with us.
Dr. Thacker,
Hi.
I hope I'm saying that correctly, or Thakkar. I don't know how to say it. I apologize.
That's
But
okay.
welcome, and go ahead and give you 5 minutes to go ahead and talk to us about your concern.
So, hi everyone. Good morning, and thank you for allowing me to talk to you guys. Can you all hear me?
Yes.
Okay. Um, so I wanted to talk about that. I tried to apply in 2019 when I had my REB exam. Like I have done the REB exam and completed, and Canadian exam and completed. So 2019, up until 2019, it was valid. I tried looking into it, and I called the Texas board and also called the PBIS, and they said that I was qualified because it was less than 5 years. But even if I passed the 5 years, because I am practicing in Canada, that's considered part of it, that it is meeting the requirement, and actually received a written notice from the PBIS that they would have processed my application on the basis of practicing in Canada, and that is considered as a part of it. And it actually said that practice included in Canada for the requirement time needed as a qualification for the credential licensure. And I received it in the writing from the PBS. And that's what they also said, that they have processed these applications, and people have received those licenses. So that's why I waited. My plan was to move to Texas last year, 2020, but COVID hit. And that's why I couldn't. And the reason I wanted to move to Texas is that I came out of the recent difficult divorce. I have a 10-year-old. Sorry. So one second. I'm by myself with him, and no family all across doing any licensing board exam. I would have had to travel to United States, which I cannot do it because of the COVID. Strict rules of the, sorry about that. Because of the strict rules of the quarantine and all. So traveling is very difficult at this point. And I just don't have no helping for the family. So, and then, one second. So I did apply last year in July when the PBIS was still active and a part of it. On the last date, July 12th, when I went to submit my application online, they said that Texas board they had a technical difficulty on that night. On 13th, I actually contacted the Texas board and also contacted the PBIS, and at that time, your website was also not updated about new recommendations. And so I waited for it. I applied again. And then on July the 31st, I received a letter saying that I need to submit an additional documentations for approval. I was in the process of doing it, but then in August, I received an application that now I'm not considered because I practiced in Canada. If it was only a matter of getting the license in United States, is different. But now that 5 years of practice, I can't necessarily prove it in United States. So it's like After that, I was advised by the board committee, especially board had been helpful trying to help me. I was advised to apply for the December board meeting. I did, but for some reason, there was some miscommunication on the dates. By the time I would have had to submit my applications, supporting documentations. And those documents are time sensitive. If you submit it a little too early, little too late, then they expire. So then I somehow couldn't be on the board agenda for December 11th meeting. So I ended up waiting till now. And for now also just for, I can't necessarily travel. If I travel, it's 14 days, 14 days quarantine requirement. Once I come back, out of those few days, it needs to be in the hotel, having a little child with me for full time with no support from anybody else, not even from the father. The kid would have to miss the school. It is going to be a lot of hassle.
Thank you for that, Ms. Thacker and
I'm sorry.
Go ahead.
I'm sorry.
Continue, Dr. Kirsch. Oh, he's not. He's on mute. Sorry, we're working through some technical difficulties. Just a second.
Can you hear me now?
Yes, we got you.
Okay.
Thank you.
Board members or committee members, do we have any questions for Dr. Thakkar? I've got a question for Ms. Studdard or Ms. Mendez. PBIS, if that had been available, would she have gotten her license in Texas? Or do we refer back to rule 101.3A2 that you must have a license in the United States to practice, or the British Columbia?
So if PBIS was still available for her at that time, she would have completed PBIS's process, then sent the application to the dental board, and we would have turned it away because she did not meet our criteria.
So we would have turned it away irregardless.
Yes.
Okay.
So
Okay.
which criteria is she not fulfilling? The fact that she hasn't practiced in the US?
Exactly. Okay. Well, do I hear a motion to deny request for exception to board rule?
Motion to accept staff recommendation of denial.
Dr. Tillman, motion.
I second.
Dr. Linda Burke, seconds. Do we have any further discussion? Seeing none, I will do a roll call. Ms. Palermo,
In favor?
Dr. Linda Burke,
In favor.
Dr. George Kirch, in favor. Dr. David Tillman,
Favor?
in favor, and Mrs. Catherine Sisk.
In favor.
Thank you, committee members. The motion carries unanimously. Okay, next on the agenda is discussion of possible action on Administration Code 101.2 licensing by examination, dental licensures, and I'll turn it over to Ms. Studdard for that.
This proposed amendment, it's a simple amendment. It's reflecting the Northeast Regional Board of Dental Examiners name change to the Commission on Dental Competency Assessments and the effective date of that name change.
Okay. With that being said, is there a possibility that we could become a member state of the CDCA? And yes, Ms. Nichols.
Yes, so I reached out to them once I knew this was on the agenda, and what we'll need to,
Okay.
if the board votes to make this change and would like to become a member, I just need to send them a letter indicating that we would like to join their organization.
Okay,
And it's my understanding that we would also have voting rights on their board at that point as well.
that's exactly right.
Okay.
So I think that'd be great for us to be able to be represented on that, since we do approve their licensing, so we can make any changes that we want on that. I know their main difference is the comprehensive treatment planning that they do. They do a DLOSCI on that, where the REV does not. The REV does a complete comprehensive dental treatment plan, so that the kids have to formulate. So yeah, I would love to have a say so on that exam. So perfect. So that will be on the board tomorrow. We'll talk about that tomorrow.
So I think best way to handle it is for your committee to make a determination that that's what you'd like to do, take a vote on it, and you can present it to the board under this 101.2 licensure examination change. Ms. Palermo has some thoughts.
Yes, I was just gonna say, I actually think that we should be researching being a member of all of the regional exams that we accept. Even though maybe our dental or dental hygiene students don't participate in some of those, we do have dentists and hygienists coming in from other states that probably have taken some of those. And for us really to make informed decisions sometimes, I think we need to be a little bit more active on them to see, what all goes on with those boards and make sure that they're all of, a high quality that we expect for our patients. So just a thought for the future. And having said that, I so move that we accept this. Would that be for hygiene too? Right?
Yes, be for both.
Okay.
Let's do two separate votes though.
Okay.
Okay.
So the first vote was for
101.2.
Yes, so board staff recommends that the committee accepts or recommends, let me start over. Board staff recommends that the committee vote to approve this rule as presented.
I so move that we
I
accept 101.2.
And with that update, we will apply to become members, right?
We're gonna do it separately, right?
Yes.
Would that be,
Sorry, that's next.
can we have some discussion? I'll second that motion as well. Am I allowed to second that, or do I need somebody from my committee to second that?
Have someone from your committee second it, please.
Okay, I'll withdraw my second. Do I hear a second on Ms. Palermo's motion to accept staff recommendation on rule 101.2? Who seconded it?
Dr. Burke.
Dr. Burke, perfect. Okay, so we have a motion by Ms. Palermo, a second by Dr. Burke. Now discuss, yes, Dr. Tillman.
Through the chair, Ms. Stoddard, if she could kind of review what staff looked at, why they made the recommendation for us, if that could be done, I'd appreciate it.
This was actually sent to me on the suggestion of a board member that we change or update this rule since NERB has changed their name back in 2015. So this is simply an update to our rule to reflect that.
So this is nothing new?
We're updating, it's not nothing new. That's correct. It's not
Okay.
new. We're just updating the rule to reflect the name change.
Okay, gotcha.
It used to be the Northwest Regional, right?
Right.
And they changed to CDCA. Yeah.
Okay.
On this motion, can we, or does it have to be a separate motion to attach for us to become a member state?
When I just attach it to this motion, since on the agenda, it's.
If the chair could accept it as a friendly amendment, it could be suggested as a friendly amendment.
If you're okay with that, that'd work for us as
The
well.
maker of the motion, Ms. Palermo. She put herself on mute.
Ms. Palermo?
One click.
One click.
Yes, that's fine.
And Ms. Burke,
Yes, that's fine. Thank you.
excuse me,
Do we
Dr.
have, do we have any further discussion? All right, all in favor?
What's the wording?
I,
Become members of CDCA.
Right. Both parts. Accept by credential and then become a member. That's the motion. Okay. Thank you, Dr. Burke.
Let me ask a quick question. We would have to become a member for ADEX as well? Because they administer the exam. The exam is actually given by ADEX, is that right?
Christine, do you know?
All I know is that ADEX is the exam.
Right.
So
Right, and CDC administers it.
So it would be, I think it would be CDCA just because that's what it's consistent with what our rules say.
Okay,
At NERB is now CDCA.
I don't know
Okay.
that we need to, I think being part of CDCA covers it, I think, but
perfect. Perfect. If we can look into that, that'd be great.
Sure.
Okay. All right, so we have a motion that's been seconded. All right, let's do a roll call. Ms. Palermo,
In favor?
Dr. Linda Burke,
in favor.
Dr. George Kirch, in favor, Dr. David Tillman,
Favor?
and Ms. Catherine Sisk.
In favor.
Perfect. The motion carries unanimously. All right, next is just same thing, but for hygienists, and it's 103.2. Ms. Studdard?
Yes, same idea here, but we're talking about the dental hygiene licensure by examination rule 103.2. And the amendment reflects that the Northeast Regional Board of Dental Examiners is now the Commission on Dental Competency Assessments, and the effective date of that will change.
And do I hear a motion to accept staff's recommendation? Dr. Tillman
Palermo, I so move.
and Palermo seconds. Perfect. And this will be attached for us as well to become a member state.
Friendly, yeah.
Acceptable, Tillman?
Is that acceptable to you, Ms. Palermo?
Yes.
Perfect. All right. Any further discussion? Seeing none. Roll call. Ms. Palermo,
In favor?
Dr. Burke,
In favor.
Dr. George Kirch in favor, Dr. Tillman,
Favor?
and Ms. Sisk.
In favor.
Perfect. Motion carries unanimously. Okay, now I'll turn it over again to Ms. Studdard to go over Rule 108.54 for advertising specialties as published in our January 8th, 2001 edition of the Texas Register.
Can I bring to light just one point about the regional exams? I don't know who may remember this or not, but in the future as well, the dental hygiene part of credits, we are a member of credits through dental hygiene, but not dental. So that may be something that we may want to look at in the future as well.
Okay. Thank you, Ms. Palermo.
Mhm.
Ms. Studdard?
Amendment, as Dr. Kirsch mentioned, was proposed at the last board meeting. It's regarding 108.54 concerning the advertisement of recognized dental specialties, and now it's up for adoption. It will update the language to include recently recognized dental specialties as approved and adopted by the American Dental Association's National Commission on Recognition of Dental Specialties and Certifying Boards. The specialties include oral medicine, dental anesthesiology, and oral facial pain. The amendment also updates the language to show that the specialties are approved by ADA's National Commission on Recognition of Dental Specialties and Certifying Boards. One comment was received after publication of the proposed rule amendment during the official comment period. The Texas Dental Association provided a written comment in support of the adoption of the rule as proposed.
Perfect. Do we need to vote on this again
Yes, sir.
since we made that change? Okay, do I hear a motion to accept staff's recommendation for code or rule 108.54 for advertising specialties?
So moved.
Dr. Burke? First and second,
I'll second Palermo.
Ms. Palermo, perfect. Any other further discussion? Seeing none? All right, Ms. Palermo,
In favor?
Dr. Burke,
In favor?
Dr. Kirch, in favor, Dr. Tillman, and Ms. Sisk.
In favor?
And the motion carries unanimously. Now, discussion on possible action for proposed rule from December 11th board meeting for Rule 119.10 oral medicine. And I'll turn it over to Ms. Studdard for this.
Yes, sir. This rule was proposed at the last board meeting. 119.10 was concerning the recognition of oral medicine as a dental specialty. The new rule recognized the specialty of oral medicine as approved and adopted by the American Dental Association's National Commission on Recognition of Dental Specialties and Certifying Boards. One comment was received after publication of the proposed rule amendment during the official comment period. TDA provided a written comment in support of adoption of the rule as proposed. Board staff recommends that the committee vote to recommend to the full board that this rule be adopted as proposed.
Do I hear a motion to accept Rule 119.10?
So moved, Tillman.
Dr. Tillman, and do I have a second?
Second, Dr. Burke.
Beautiful. Any further discussion? Thank you, Dr. Burke. All right, seeing none. Ms. Los Palermo,
Can I just ask a quick question?
absolutely.
Okay, what would be an example of this?
Meaning an example of oral medicine as a subspecialty.
Right. I don't know what it means when it says medically related diseases and
Complicated, yeah.
What?
Complex patients.
Yeah,
what? Oh, complex patients,
Yes.
health-wise?
Yes,
Does that include like cystic fibrosis and cerebral palsy and those kinds of things?
yes.
Ms. Nichols?
Sorry, I didn't understand the question. I was gonna state that to apply for the specialty, they'd have to go through the ADA and they would verify whether the person, I didn't understand your question though. I see what you're asking now.
No, that was a good point too, though I hadn't thought of. In favor?
Okay. Dr. Burke,
In favor?
Dr. Kirch, in favor, Dr. Tillman,
Favor.
and Ms. Catherine Sisk.
In favor?
The motion carries unanimously. Okay. All right, Ms. Studdard, would you lead us on our next discussion, please?
Yes, the next rule that we are going to discuss is 119.11.
Cut off, okay.
Proposed at the last board meeting, and it was concerning the recognition of dental anesthesiology
Anesthesiology, okay.
as a dental specialty. The new rule recognizes the specialty of dental anesthesiology as approved and adopted by the American Dental Association's National Commission on Recognition of Dental Specialties and Certifying Boards. One comment was received after publication of this rule. The TDA provided a written comment in support of adoption of the rule as proposed. Staff recommends that the committee vote to approve, or board staff recommends the committee vote to adopt the rule as proposed.
Do I hear a motion for staff recommendation to adopt this rule?
Palermo, I so move.
Palermo, thank you. Do I have a second?
I second, Dr. Burke.
Dr. Burke, thank you, Dr. Burke. Any further discussion? All right, Ms. Palermo,
In favor?
Dr. Linda Burke,
Favor.
Dr. Kirch in favor, Dr. David Tillman,
Favor.
and Ms. Catherine Sisk.
In favor.
The motion carries unanimously. And now we'll discuss 11912 oral facial pain. Ms. Studdard?
This rule was also proposed at the last board meeting and is now up for adoption. It recognizes the specialty of oral facial pain as approved and adopted by the ADA's National Commission on Recognition of Dental Specialties and Certifying Boards. One comment was received after this rule was published. The TDA provided a written comment in support of adoption of the rule as proposed. Board staff recommends that the committee vote to adopt the rule as proposed.
Do I hear a motion?
So moved. Tillman.
Dr. Tillman, do I have a second?
Palermo, I'll second.
Thank you, Ms. Palermo. Any discussion?
Tillman, just an observation. You know, we've visited the use of Botox and other medicines in the relief of pain. We may,
Medicinal? Mhm.
yes, thank you. We may, thank you. We may need to revisit that down the road because now we've added a subspecialty. So just an observation to be on the lookout, but you know, I'm definitely in favor of the motion. Thank you.
I've got a comment as well. Go ahead, Ms. Nichols.
I just wanted to let this committee know that the Dental Practice Committee will be discussing that this board meeting.
Yeah, and will this include TMJ specialists now? Will this be a specialty for TMJ?
I do not know.
So
I will look into that.
my understanding is that these are kind of rolled into one. Oral facial pain, TMJ is a part of that.
Okay.
You know, that's my understanding, but
Because there are some who call themselves TMJ specialists. And-
Correct.
And there's not a specialty for that. I was curious if this was going to let them join and combine this.
yeah, it may not. I mean, you could, TMJ is not a quote subspecialty, just like implantology is not you can advertise, right?
Exactly.
You know,
Okay.
if you're oral facial pain, it would probably include TMJ pain as well.
Okay.
Do some
Yeah,
research.
I'll look into it.
Okay. Thank you. That's the only comment I had. Any further discussion? All right, Ms. Palermo,
In favor?
Dr. Burke,
In favor.
Dr. Kirch in favor, Dr. Tillman,
Favor?
and Ms. Catherine Sisk.
In favor.
Ms. Catherine Sisk?
Sorry, in favor.
Perfect. Great. It carries unanimously. Okay, do we have any public comments at this time?
No, sir.
Wow, okay.
Just a
Oh,
I don't know if she was told that she knew.
So, Dr. Kirsch, we do still have Dr. Thacker on the line. We may need a clarification to her of where we are after the vote. I don't know if that was done. That might be appropriate.
Okay. Do you want me to do it or do you want, Ms. Studdard, can you go ahead and do that?
sure thing.
I don't know. She's coming back.
I'm sorry, I skipped that. I thought we had done that.
Sure.
Back on, she's probably enabled the audio.
Hi, Dr. Thacker. We just wanted to clarify something. If you could unmute yourself.
Hello?
Hi, Dr. Thacker. We just wanted to clarify something about the committee's recommendation. So the committee today to deny your request for exception to board rule. That exception is going to go to the full board at tomorrow's meeting for a vote. So they can vote to either accept that recommendation or they may discuss another option. So you have the option to attend tomorrow's board meeting as well to provide comments.
Question.
Okay.
So today, today they decided that I will not be exempt. That's how it is.
Right, they voted to deny your request. For
Okay, and I have another question. It mentioned about the British Columbia, the practicing in British Columbia or having the license in British Columbia. What does that had to do?
From Dr. Tillman, a word of clarification. That means the District of Columbia, meaning Washington DC, District of,
Oh,
not,
okay, sorry.
I'm sorry.
Sorry.
Yeah, no, not a problem.
Reason I'm not accept that, is it because I have not practiced for 5 years in United States, or I didn't have the license for, or both?
It's because you have not held a license in the United States.
And,
So if
and
I had a license,
from
sorry.
Dr. Tillman, and practice 2 years is, I think, the part of the stipulation. Is that correct, Ms. Studdard?
Ms. Mendez would like to clarify that.
3 years, Dr. Tillman.
3 years. Thank you, Ms. Mendez. Thank you.
So both,
Right.
Correct.
okay.
So again, this is a
So
recommendation.
how about,
And so the full board will hear the committee's recommendation and discuss tomorrow if you'd like to call in and join the discussion tomorrow as well.
sure, I will. Thank you,
Thank
Thank
you.
you, Dr. Thacker.
thank you.
Do we have any other public comments? No?
Yeah.
I don't have any announcements. Dr. Tillman, do you have any announcements? Or board members, do y'all have any announcements? Okay, do I hear a motion to adjourn?
So moved, Tillman.
Do I have a
Second, Palermo.
Dr. Okay, all in favor, just show by hands. All right, motion carries. Thank you guys very much. I appreciate it. This went a lot faster than what I thought. I thought we were going to be here for a long time. Wow. Good job, guys. Appreciate y'all.
Thanks.
I'll see y'all tomorrow. Thank y'all, staff.
Thanks.
Now I have 10:41. Is that right?
Yep. Thank you, Dr. Tillman. Always on the 10. Thank you very much.
If any committee members decide to stay on the line, please just mute yourself until our 12:30 down starts.
Bye, guys. See y'all tomorrow.
I don't-
Is Lauren still on?
And we are streaming, so
Oh.
it's unmuted now.
We're streaming, Dr. Palermo, Ms. Palermo. Go ahead.
Okay. No, I was just gonna ask about, wasn't there on the state board website, and we received an email about some fraud that was going on with the board name or something?
I'm going to address that tomorrow. I'll be talking about that just to give everybody an update.
Okay. No, because, well, I have a dentist that called me and has been having some problems, I think, with that. And I didn't know where to direct him. Okay.
All right.
Thank you.
I think we're ready. I'll watch my video.
Okay. Hi, guys.
Good afternoon.
Okay.
Yes.
Hi, Dr. Yu.
Hi. Hi, Case. How's it going? How's Rory?
Oh, she's very good. Thank you for asking. Hopefully in June, I'll be able to bombard you with pictures and video.
Well, let me know when you guys are ready.
Ready when you are. We have it looks like your committee members are all on,
except for Mr. Bustamante.
and we don't anticipate that he'll be joining us. We have not heard from him.
Okay. Y'all ready? All right. So let's convene. So this is the March 11th, 2021 Dental Practice Committee meeting of the Texas State Board of Dental Examiners will now come to order. The time is 12:32. So I want to remind board members, if you're listening to the meeting on a secondary device, computer or tablet, please mute it until it is your time to speak. Also, please say your name before your verbal vote during the voting process to ensure a proper count. I'll also be announcing the names of board members and committee members when addressing them on first and second motions. I have the honor to read the mission of the Texas State Board of Dental Examiners, which is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. So at this time, I'd like Ms. Nichols, if you don't mind, to read or to call the roll and confirm that a quorum is present.
Yes, sir. Dr. David Yu,
Present.
Ms. Lori Jones,
Present.
Dr. Brian Henderson,
Present.
Mr. Rodney Bustamante. It's not on the call. Dr. David Tillman.
Here.
Dr. Yu, you have a quorum. Thank you very much.
Thanks, Ms. Nichols. So the first item of our agenda, our short, hopefully, agenda is discussion and possible action on dentists administering the COVID-19 vaccine. I'd like Ms. Nichols to lead discussion on this topic, please.
Thank you, Dr. Yu. So the board staff we've received a lot of inquiries from practitioners and stakeholders requesting our stance on dentists administering the COVID vaccine. We learned recently at the AADB conference that there are currently 24 states that allow dentists to administer the vaccine and 9 states that allow dental hygienists to administer. Those states either had a statute change or an executive order from their governor allowing dentists to vaccinate. And that is because the scope of practice for dental professionals and dentists specifically is defined as being limited to the human teeth and oral cavity. So the scope is broadened for dentists that have the oral maxillofacial specialties, but for our regular DDS dentists, that would be there's a limited scope of practice. So in North Carolina, dentists were recently allowed to begin vaccinating by an executive order. But so far, we've learned that only 12 of their dental offices in that state have actually registered to get vaccinations because of all the requirements that are involved. So our practitioners would be required to adhere to the HHSC or DISH's guidelines. You'd have to register your clinic. You would have to attest that you have the ability to have personnel giving the vaccination. You'd have to have the storage that keep the vaccine cool. There's a lot of hoops to jump through. So the bottom line at this point, as far as our agency is concerned, is that we'll need some type of legislative change or executive order from the governor's office to allow dentists in our state to vaccinate. It's my understanding that Health and Human Services and DSHS are not currently registering dentists to vaccinate. The issue right now is not necessarily the number of practitioners who are eligible to vaccinate in the state, but the shortage of the actual vaccine available to meet the public demand. So should there be an influx of vaccinations available, should Texas be able to meet the demands of citizens who want to be vaccinated, then hopefully the governor's office would update either give some kind of executive order or update the board to let us know that they would like our licensees to begin vaccinations. Thank you, Dr. Yu.
Thank you. Any comments from my committee members on this? So, Miss Jones.
Sure, thank you. I was just wanting to clarify and make sure I'm understanding correctly, Ms. Nichols, is that it would take an executive order or a change in statute for dental professionals to be able to administer vaccines in Texas.
Yes, ma'am.
Okay.
And I do appreciate stakeholders and licensees being so interested in helping out. And just like Ms. Nichols says, it's really out of our board's hands. It really is just dependent on exactly that. And you know, Ms. Nichols referenced the AADB meeting in which, you know, Ms. Nichols and Dr. Henderson and myself were a part of. And what was really interesting is all the information that we're getting out from these states. Like, for instance, the PrEP Act, which is the Public Readiness and Emergency Preparedness Act, and it limits liability or immunity to COVID, you know, vaccine or administering or even the whole COVID issues, you know, but not willful misconduct. And ADA themselves are working on a national level to allow dentists to administer. But you know, Ms. Nichols also referenced North Carolina, where it's, you know, their sort of rules are interesting because they have 3 methods of vaccine administration for dentists. And Ms. Nichols mentioned about, you know, the offices being able to give vaccinations through their office, and only 12 of them are doing that, as you mentioned. But it has to be in agreement with the CDC, a provider agreement. But also the other methods is in medical clinics supervised by MD or DOs, and also vaccination clinics without supervision of MD DOs. And you know, it's kind of interesting that there's 3 methods on that. I don't know, you know, whether we're going to be able to do it, or you know, what our, you know, sort of way to do it are going to be based on legislation or an executive order. But I think, you know, in terms of, you know, I know the public is sort of wondering, why do we even care that dentists can vaccinate or not? And I just think that dentists are untapped resource. I mean, we're expert at injections. We inject more than any healthcare provider, and it's not even close. So we have the manual dexterity to give some of the most difficult blocks and infiltrations. And think about the most challenging confined spaces in the oral cavity, while we're avoiding nerve trunks, vessels, plexuses, vital structures. So, you know, arms we can do. Arms are nothing. I mean, we're comfortable with needles. And that's why, you know, a lot of dentists are interested, because they feel like we already have the skills for it, because we're, you know, used to needles and we're good at it. And it's really not a moneymaker. I mean, all of this is going to be, you know, volunteer, as far as if we're volunteering at vaccination clinics or whatever. But I just, you know, want the public to not underestimate the, you know, resource that they have in terms of dentists, if the governor and the legislators choose to have dentists involved. But the system is already in place for training. You know, the CDC has a vaccination online course. But, you know, like I said, I just don't, I urge the public and policymakers not to minimize our expertise if it comes down to it. Okay. Any other comments from committee members on this? Dr. Henderson? Nothing?
Yeah, Dr. Yu. Very nicely stated, and Ms. Nichols, I want to thank you for the time and the research in doing this. And I'm going to just speak as a public person, a dentist, that I think dentists would be willing to give any administration of any vaccine that the governor asked us to, as far as a manpower. I don't think we need a statute change. I think it would be something that once we get the population of Texas inoculated, it'd be something that dentists wouldn't care to do. It could be that we set up and man some of these already existing vaccination sites as far as manpower. So that could be something that as well, without necessarily having to be responsible and maintain these vaccines in our clinics or offices. So we're here to help the state of Texas and the governor any way we can, but I too don't think it's worth the hassle of changing all the rules. Thank you, Dr. Yu.
Thank you, Dr. Harrison. Any other comments from my committee? And I think, most likely the way dentists will proceed, if they're allowed to do this, is to help out, volunteer in these clinics and vaccination clinics. It's, in my mind, it's too difficult to be an administrative or administration, however you say it, business. Okay, so if there's no other comment, let's move on. And so the next agenda item is discussion and possible action on rulemaking pertaining to Botox. And I'll go ahead and lead discussion because I know there's been a lot of confusion on, the public and especially licensees concerning what they can and can't do in terms of the Botox discussion. And I know the original, and obviously you all know about the policy statement that we have, right, in our board website. And that was published back in 2010, I believe. And if you don't mind, Ms. Stutter, can you pull that up and review that statement with the committee?
Okay, so our policy statement says the DPA does not specifically address facial cosmetic surgery or treatment, but it does define the scope of practice of dentistry as being limited to human teeth, oral cavity, alveolar process, gums, jaws, or directly related and adjacent masticatory structures. This scope is broadened for dentists with an ADA recognized specialty of OMS to include the diagnosis of and surgical and adjunctive treatment of diseases, injuries, and defects involving the functional and aesthetic aspects of the hard and soft tissues of the oral and maxillofacial region. So we go on to say that based on the language of the statute, the board has determined that the use of facial cosmetic procedures outside the somatomatic system is not within the scope of practice for a dentist who does not have the specialty of oral maxillofacial surgery. The products and procedures included within the heading of facial cosmesis, which includes Botox, can only be used for the diagnosis and treatment of functional issues of the somatomatic system as part of a comprehensive treatment plan. However, their use for isolated cosmetic purposes is permitted only for those dentists who have the specialty of oral and maxillofacial surgery.
Now, and thank you, Ms. Studdard. I just want to reiterate that the policy statement is just a reiteration of what's already in the Dental Practice Act. Injectables can be used as long as there is therapeutic dental justification for it, and not solely for unjustifiable uses. So, for instance, I use Botox. I do at no charge, for instance, in every all-on-4 case where heavy bruxism is the etiology for tooth loss, and to lessen the intensity of forces against my newly placed implant as they osseointegrate. So I don't treat it, but Botox is, I don't use it for bruxism type cases, but, for a lot of patients or a lot of practitioners, it's useful for, myofascial pain situations, TMD, which is in the scope of dentistry, because, part of the Deep Dental Practice Act says that we can work with adjacent masticatory, I've had that problem too, Laura, masticatory structures. And so that's, I want stakeholders and our licensees to recognize that you have to have dental justification. I'm not asking for some kind of rule change or a new rule on this or anything. I'm okay clarifying it with a policy statement or redoing it. But I think the Dental Practice Act is the Dental Practice Act, and that's what it is. So I don't know why there's some confusion on this. Ms. Jones.
Well, I was just wondering, I think that I hear the confusion coming in from the fact that there's a lot of courses being offered across the state, right? And dentists can go and be certified in administering these facial cosmetic procedures. And so I think, by having us talk about this now and reiterating what is in the Practice Act, and that's not something that we can change as a board. That is something that has to go through the legislative process. So I think that's where I hear the concern is like, well, why are we having all these courses available around the state when that's not something we can do?
Thanks, Ms. Jones. Dr. Tillman.
So the AGD is having their national meeting here in Austin in June. So we'll find out in April whether the city of Austin will allow for 50% utilization of facilities. And if that occurs, then there's going to be a meeting here. One of the courses in that meeting is a young lady, a dentist that does teach Botox, but it's to national dentists. So that would be offered here in the state of Texas. So I could see where that could be, a challenge under our statute. And so that's probably a part of the confusion and the challenge as we in Texas host national meetings or meetings for clinicians that are not only within the state of Texas, but have board certification in other states that the Botox or fillers or whatever are allowed. So just to kind of clarify what the challenge is.
Ms. Jones.
And I do understand national meetings. I mean, we have national meetings here in Texas that give local anesthesia refresher courses. So, or the initial courses. So like, I understand that. I think what I was hearing is just the pop-up courses around some of our major cities that dentists can sign up for. So nothing national. Like I understand national, and when you're serving a wider audience. But I think too, like just us doing right now, I think this will help to clarify.
Dr. Tillman again.
So one thing that I would put out there as a suggestion is during this meeting, we are recommending the creation of specialties as recognized in Texas for dental anesthesiology, oral facial pain, and oral medicine. Now, currently, from my understanding, the use of Botox by any other clinician other than an oral maxillofacial surgeon is prohibited. So if in the situation of, say, an oral facial pain dentist now created under Texas law, that Botox could potentially be used in the injection for the relief of pain. Now, that would not be outside of the scope of that new specialty, but I would just ask for staff to look at, with the creation of these new specialties, look at the existing Practice Act as it relates to these new specialties and see if there are any kind of ramifications in situations similar to Botox, to where there might be a need to make sure that our Practice Act relates to those new specialties. Thank you.
And if I may, just to clarify, if you can justify dental therapeutic, with the use of Botox, it is allowed.
Okay.
But for aesthetics only that have nothing to do with a dental therapeutic reason, then that's where the Dental Practice Act will kind of, is not in the Dental Practice Act. And honestly, it's I mean, it's not that the dentist doesn't have the skill for it. I know in my dental school, the first 2 years, my training was exactly what, courses the medical students took. And in fact, I had an extra course or extra class on head and neck anatomy more than the physicians did. And so I think dentists know the head and neck structures better than anyone. And we can use our hands with injections, as I talked about with vaccinations, better than anyone. But our Dental Practice Act does not allow for the scope to be outside of what dentists you do based on masticatory structures. But in terms of CE, I just took a course on a drug called Dasuvia. Brian, you know that it's sufentanil, and obviously in our rules, I cannot use that. Okay, but I still took it because I want to learn about it. And even during quarantine, I did CME on neurosurgery just because I was interested. But I'm not going to start doing brain surgery. So I think it's incumbent on, and obviously national meetings have to take place somewhere. Why not Texas? But I think it's incumbent on the providers, the course providers, the lecturers to specifically talk about some of the rules in the particular state that they're giving the CE on. So I think that's the important part. I think it's important for dentists to learn outside what they normally do, but you got to stay in your lane, and they have to know what the lanes are. Okay. Dr. Henderson.
I too have to make a comment on this. I can appreciate all these suggestions of Dr. Tillman, Ms. Jones, yourself. It's a multifaceted. I think we've covered a lot of things. Do I think Texas should host continuing education? Yes. Is it okay if Texas hosts education that's beyond whatever scope we have and limit in Texas? I think yes. I mean, we should be educating and trying to draw businesses and practitioners from neighboring states and other parts of the country who want to visit Austin and San Antonio and Dallas and Midland, Odessa, to have some kind of draw. And I don't know it's really the person who's given the lectures duty, but the licensee who has the license to understand where the restriction is and wherever state they practice. Because like you said, you went and took a sufentanil course on an educational process. We all learn things beyond our scope because we have to be able to communicate and understand how that impacts both as a regulator and as a clinician. So I think that's great that people are doing that. And as far as clarifying the Botox situation, I'm going to ask Ms. Studdard, are we having, I know we've seen some in ISCs who claim they do fillers and Botox as general dentists, and they put it on their website. And clearly that's not within their scope of practice. And we know that. And Dr. Yu says he's used Botox for muscle paralysis for bruxism. I've used it for chronic pain as well and trigger points. And Dr. Tillman's correct, with pain management specialty coming out, more people are going to be doing that. So it's certainly within the scope of dentistry. And if we need to clarify even our position statement, if we don't want to write a rule, I think it would be worth having staff maybe look into this in case they want to propose a rule, or if it's okay as a policy statement. It's kind of the only policy statement we have as a board. And it's kind of offsetting it. Back when Alex was general counsel, we talked at length about these policy statements and do we want to use it more or we want to use it less. So I'm going to probably ask Ms. Studdard to get with Ms. Nichols and determine what the agency think is the best way to handle this, because it could be we remove it off a policy statement and we make it a rule, or we clarify the rule, the policy statement to incorporate some of these other comments that we're reading. So that would be my motion or suggestion to the committee.
So, okay, to clarify, we're looking at kind of, potentially clarifying the policy statement and or making a rule on this. To me, Dental Practice Act is Dental Practice Act. I mean, we're not adding anything by creating a rule. But now that said, I like the idea of maybe clarifying the, policy statement, even though a policy statement isn't a rule, but it's kind of our position on our interpretation of the Dental Practice Act. Does that make sense? So, like I'm fine either way, but, are you making a motion, Dr. Henderson? Dr. Tillman?
So that was my motion, to let staff determine if we're good where we are, come back and report to us, because as we've kind of covered, is it okay for the people who lecture on Botox and teach something that's outside? Is that something we need to be concerned about in their opinion? And is it okay if we understand as a licensee we can use Botox both for masseter, bruxism, and aesthetic if you're an oral maxillofacial surgeon? And if we're happy with the policy statement and it's clear, then we can just point to the policy statement. If we're having a number of licensees and we can identify that we need to either put it in rule or clarify that policy statement, I think this would be an opportunity to consider that. And so I'm going to ask that we get feedback from agency regarding this issue, and that was my motion.
Okay. Do we have a second on that motion? Dr. Tillman, seconds. Further discussion? Okay, let's roll on this. Ms. Jones?
In favor.
Dr. Henderson,
Or
myself in favor. Dr. Tillman?
In favor.
All right, so motion passes to allow staff to evaluate potential rulemaking on Botox. Okay, so next on the agenda is discussion and possible action on a currently proposed rule from December 11th, 2020 board meeting on 22 Texas Administration Code 108.8, records of the dentist, published on January 8th, 2021, edition of the Texas Register. I'd like to call on Ms. Studdard to lead discussion on this, please.
Dr. Yu, as you mentioned, this rule was proposed at the last board meeting and it's now up for adoption. And it's an amendment to Rule 108.8 that specifies the maximum cost a dentist can charge a patient for duplication of the patient's CBCT scan. We did receive one comment after this rule was published. It was from the TDA, and they are in support of adoption of the rule as proposed.
Thank you, Ms. Studdard. Any comments? So basically the rule was just to include cone beam CTs, and I do like Texas Dental Association's comment that it should be part of the permanent record, and that's not something I'd recommend that we put in the rule, but that's kind of inferred with this. All right, so do we have any motion on accepting this rule? Ms. Jones?
I move to accept the rule as it was published in the Texas Register.
Thank you. Do we have a second? Dr. Henderson, seconds. Thank you.
Thank you.
Appreciate that. So any further discussion on this? Here none. Let's roll. Ms. Jones?
For.
Dr. Henderson?
For.
Dr. Yu? For. Dr. Tillman?
For.
Unanimous in favor of accepting the rule as published in the Texas Register. Thank you, committee. Next on the agenda, public comments. Do we have any public comments?
Yes, Dr. Yu, we have 3.
right? Four, we have four now.
Whoa, okay.
Yes, one at a time, please. So just who's first on the list?
There's a Ben Ratcher.
We'll let, is it Dr. Ben Bratcher?
Yes, Dr. Ben Bratcher.
Dr. Ben Bratcher, we'll let him go first. So we're gonna invite him to the meeting. He's joining now, or should be joining now.
Yeah, I see him.
Okay.
Should we just enable audio?
Yep.
Is he on?
You should
Dr.
be
Bratcher?
Yes.
should be able to hear you now.
Yeah.
Yes, can you hear me?
Yes.
Yes.
Okay, thank you for having me. And I'm going to apologize up front. I was just in the process of sending Ms. Nichols an email saying, in light of your comments and in light of the discussion, we really don't have a lot to add to what y'all were talking about. I do want to make just an encouragement that I don't, and I think the TAGD doesn't, I'm sorry, I'm Ben Bratcher, president of TAGD. I didn't introduce myself. Our position would be that just because it's hard doesn't mean we shouldn't do it. So I think hopefully we'll all continue to work. I appreciate the support Dr. Yu and others gave for the ability of us dentists, us little dentists, to pitch in and help out with the COVID problem. And then the others that we will, based on your comments, we'll definitely start working with our legislators to see if we can get some of those statutes changed, or maybe the governor's office, see what we can do there. So thank you for your support. I'm sorry for the delay. There's not really a way to duck out of these things, and I didn't want to be rude and just not be here. So thank you for your time, and I appreciate all that y'all are doing.
Appreciate your work. Take care, Dr. Bratcher.
All right, who's next on the list?
There's either Diane Rhodes or Louis Matcher.
All right, it's Dr. Malkmacher.
Yes.
Yes.
Let's let Dr. Malkmacher go next, because I think he was logged in.
Take care, Dr. Bratcher.
Who's next on the list?
Maybe on the YouTube stream as well.
If you are streaming the meeting behind you or in the same room as you, Doctor, will you please put it on mute while you're speaking to the board, because it creates a residual sound.
Echo.
We're ready for you.
Okay. I'm sorry, I didn't hear my name called, so I apologize. Let me just start my video. And hi, everybody. Great to see you. Thank you very much for the time. If it's okay, if it's possible to share my screen, that would help with this presentation, and go a little bit more expeditiously, if that's possible. Is that possible?
Yes, sir. It should be at the bottom of your screen, the little share screen button. It's green.
Right. There we go. Okay. Hang on one second. Here.
Doctor, if you could limit your comments to 5 minutes, that would be appreciated.
Yep, I'm going to try to get through this as quickly as I can. My name is Dr. Louis Maltzmacher, and I'm president of the American Academy of Facial Aesthetics. And I caught most of the Botox discussion. I didn't know that I was supposed to go to the YouTube to hear most of the meeting here. But I just want to give you a perspective. I'm going to give you, because I was involved with this, with the policy statement 10 years ago with the Texas Dental Board. And we've actually had many Texas Dental Board sitting members over the years take some of our Botox and fillers course. I just want to give you a little bit of perspective of where this is around the country. And then how it relates to Texas and what we've been working with Texas and different board members over the years. But Botox and fillers is not new. We kind of fought this battle about 10, 12 years ago for all of this. I think it's important in light of some of the comments that you've all made. 95% of Botox and filler use is both therapeutic and aesthetic together, and you can't separate them. They kind of come together. They're among the safest dental procedures, I would probably say. Over the 10 years that Texas dentists have been doing Botox and fillers, that you have had maybe a handful of patient complaints or negligence when it comes to Botox and fillers use. And dentists in Texas have been using it for 10 plus years, as they have around the United States. We at the American Academy of Facial Aesthetics, we present our Botox and filler live patient certification training with the ADA at the ADA annual session and at ADA headquarters. So certainly it is part of normative dental practice for general dentists all across the country. I mean, there are probably 25,000 general dentists around the country presently using Botox and fillers within the scope of practice. The way that other states use it, and I have been involved in nearly every state dental board when it comes to this issue, is they simply say, listen, whatever you provide to your patient, if it's in the Dental Practice Act and you can document it appropriately and show how it's within the scope of dental practice, then it's in. If it's not, it's not. There are three states that do have their own requirements in terms of education. All three of the states were 5+ years ago when this was relatively newer and they weren't exactly sure what they were getting into. None of the other states have an educational requirement for this because it's no different. If you have an educational requirement for Botox and fillers, we darn well should have one for implants because somebody just coming out of school can drill 10 holes into somebody's head and put in implants, and they may not certainly have the training for all of this. And actually, I presented at the American Association of Dental Boards about 5 years ago, I want to say, and every dental board in the country, and this was Botox and fillers have been in use already, and not a single dental board member raised their hand ever remembering having any kind of patient complaint or issue with Botox and dermal fillers. And that's a statement to the safety of it. And at this point, dentists have been doing it safely for 12 years. And I think that's impressive. Dental education and injectables, Botox and dermal fillers from 2008 to 2021, you'll be hard pressed not to find a university or an annual or regional or state meeting, including the Texas Dental Association, which I presented at a number of years ago. And I believe they've had other courses on injectables there as well. Just to give you an idea, and this is just to give you perspective in how it's used in dentistry, certainly masseter reduction, which some of you have talked about. TMJ, oral facial pain. Botox is FDA cleared for the use of migraines and oral facial pain for treatment all the way down to the neck and shoulders. And that's where we have trigger points that is taught in every dental university oral facial pain residency. Certainly it has the aesthetic effect as well. And I could show you case after case, just another case of masseter reduction. I could speak for an hour in each one of these cases, but I won't. Gummy smile. There are different ways to do it. I can do it surgically in dentistry, or I can use some Botox and dermal fillers with some lip enhancement for dermal fillers to hide some of the gums, some Botox to relax the upper lip muscles for all of these. This is a perfect case when it comes to the use of Botox and fillers in the scope of dental practice, and it would fit certainly into Texas as well. Mid-face, if you lose volume in your mid-face, every dentist knows this, as people get into their 40s or 50s, their upper lip drops, they hide their upper teeth, and that's purely because they've lost collagen in their upper face. When you replace that collagen, look on the right-hand side of your screen, and you can certainly see all the way to the right, after the patient has had some mid-face replacement of dermal fillers, that smile is much bigger, and that completely changed her smile and lip lines because it gave her the support that she needed for dental aesthetics there as well. And that's just another view, so you can certainly see for that. But the smiling view in here certainly puts this well within the scope of dental practice, as it is around the country and as it is at every ADA course. By the way, we had an ADA annual meeting course that we presented at in San Antonio, I think in 2014. So this is not a new issue by any means. Here is, believe it or not, an older patient, and I would know because I am married to her, but you can go ahead and see, look at her smile before. That's another reason, that's another time where she's lost a lot of collagen and fat in her mid-face, depressed her smile. We kind of call that the mad dog smile because she's got to use some other muscles that don't typically raise the upper lip to kind of, try to get into a full smile, whether you replace the volume with dermal fillers in her mid-face, and she's got her complete smile lines and lip lines back. This happens to be a Texas dentist who had an asymmetrical gummy smile, and she could have had a Lafort maxillary 1 fracture. She could have had orthodontics. She could have had a number of different things. All she had was some Botox and dermal fillers in her mid and lower face, and that went ahead and do that. Understand too that Botox and dermal fillers are both temporary procedures, and that's one of the reasons that they are very, very safe for that. So that's the scope of general practice in general. Now, I mean, I can tell you the history behind it. I mean, if you wanted to dig deep into this, I could literally go through every single line of this and tell you what's wrong with it, but there are so many contradictions in this statement. I would venture to say it has confused dentists in Texas, the dental board staff. I know I've spoken to some of the Texas dental board lawyers over the years, and they all really dislike this statement because it just doesn't make a whole lot of sense. And it certainly doesn't reflect the scope of dental practice where we are. But I'm happy to dive into this with anybody that would like to on or off of this meeting at any time to tell you what's wrong with it. Basically, if you look carefully, I think one of the unintended consequences of this statement as it's a policy statement, and I understand it's not a rule, and I think a lot of dentists have pretty much ignored this, saying that, you know, this is just a policy. We know it's not the Dental Practice Act. One of the unintended consequences of this statement actually allows dentists to do something called microneedling on the surface of the skin, because they can treat the epidermis of the stomastognathic system, which the term does not exist in the Dental Practice Act. So it's kind of irrelevant, you know, to this whole issue here. But for all of this, and nowhere also, I would say, and you know, when it gets to the Dental Practice Act itself, the Dental Practice Act does not exclude cosmetic-only procedures at all. And if it did, then I would say Texas dentists would have a hard time giving up porcelain veneers, purely cosmetic service, whitening, purely cosmetic service, and you pretty much have a real revolution on your hand for all of that. If you're going to say that based on this policy that only oral surgeons can do porcelain veneers and whitening, I think that might upset a few people in addition to patients for all this. In our opinion, this policy statement is contradictory, factually wrong, speaks in double negatives, and really contradicts the Dental Practice Act as it stands, and should be eliminated for all this. Texas dentists already have a 10-year history of safely providing these for aesthetic and therapeutic outcomes. In our opinion, and we've worked with every dental board practically, the Texas Dental Practice Act as written already includes the use of Botox and dermal fillers. Every dental board says, listen, if you can justify it as dental treatment, it's in. If you can't and you can't document it, then it's out. If there's a patient complaint, they're going to have to come to the board and discuss why it was within the scope of dental practice. And indeed, I can tell you, I know for over the past few years, dentists who have come before the Texas board, and the Texas board pretty much said, okay, I mean, if this was documented, then that's good to go for all this. I don't think like most of the other states, in my opinion, Texas does not need any new rules, policies, or anything else, because they've been doing it in Texas for a long time, very safely. I heard a YouTube, I guess, I don't know if it was, you know, one of your dental board meetings where, you know, one of the dentists was, the dental board members was, you know, very concerned that this is really going to hurt people. That might have been a conversation that we had 10 years ago, but at this point in time, we've got 10 years of safety behind us. Dentists have been very good, and Texas dentists have been very good at providing Botox and fillers, both for aesthetic and therapeutic outcomes, safely for their patients. And certainly that's what the board is made for, is to go ahead. It's all about patient safety for all of that. And that's, I'm happy to entertain any questions if you have for me, or, you know, I appreciate the opportunity to at least speak with you.
Thanks for coming on, Dr. Malkmacher. You know, I understand your take on it. I do believe, you know, that Botox is one of the safest things that we can do, because obviously with implants, we could stick it in a nerve, you know, a lot more invasive things that we do. And, you know, the worst case scenario, the Botox goes to a different muscle that we didn't intend, but it's reversible. It'll go away. I'm not reversible, but it'll wear out. But, you know, in terms of and I'm specifically concerned about our statute, because, you know, the Dental Practice Act to me seems pretty clear that there's, you know, that we can do it therapeutically as long as there's dental justification, but not specifically for aesthetics. And I'd like our attorneys, to chime in, Lauren, about how the Dental Practice Act is interpreted in this manner.
Right, so I mean, like our policy statement states, products such as Botox can only be used for the diagnosis and treatment of functional issues of the somatic system as part of the comprehensive treatment plan. Botox can be used for isolated cosmetic purposes, it's permitted, but only for those dentists who have a specialty in OMS.
So how is that not sort of paraphrased from the Dental Practice Act, or is that? I assumed it was paraphrased from the Dental Practice Act.
No, it's that paraphrase is not specifically stated in the Dental Practice Act. We got that from the scope of practice that's defined in the Dental Practice Act. So the policy statement is the board's interpretation of what is the scope of practice regarding this issue.
So legally, how does that stand? I mean, like if, okay, let's be, let's take the other side. Let's say a dentist is doing Botox cosmetically, and that policy statement says that only oral surgeons can do it. Okay, but we know that oral surgeons do not get trained specifically with Botox. I mean, dental students don't get trained with it, and oral surgeons do not get trained, and their training, yeah, understandably, if a dentist is doing a Lafort osteotomy, yes, they are not trained to do that, but oral surgeons are not trained in their residency to do Botox. So, if all dentists are beholden to the Dental Practice Act, is it reasonable to single out the field of oral maxillofacial surgery to only be the only dentist to be able to do it? That's my question, Dr. Malkmacher.
So I will respond, and with all due respect to Ms. Studdard, I mean, she quoted the policy for that, but nowhere in the Dental Practice Act, Botox is just a pharmaceutical. Botox, I don't know why it is, but people like to kind of treat Botox and dermal fillers as something on its own. It's not the only new technology that's come into dentistry in the last 20 years. You've had lasers, you've had CAD/CAM, you've had implants have gone, through the roof. I mean, I can name a whole bunch of others. Botox is no different. All Botox is a pharmaceutical. Dermal fillers is a medical device. And in the Dental Practice Act, there's clearly a statement that says that a dentist can go ahead and use any pharmaceutical, any medical device within the scope of dental practice. Nowhere in your dental practice does it say exclude aesthetics. And if it did, you can't treat Botox separately than you can porcelain veneers. Many porcelain veneers are only used for aesthetic purposes with no functional. I know I've taught porcelain veneers for 40 years. You would exclude whitening. So there's nothing that excludes that. And interestingly, in the Dental Practice Act in Texas, when it gets to that oral and maxillofacial surgical thing, it uses the term, not just aesthetic, it uses the term functional and aesthetic treatment for hard and soft tissues for all of that. And so are we going to now say, well, we're excluding aesthetic for general dentists because it's only written that for oral maxillofacial surgeons? We're also going to exclude functional treatment because that's what it says, only by oral maxillofacial surgeons. There's a wide variety. And by the way, one of the things in the Dental Practice Act in Texas, and this is very common, is not just about disease and those kinds of things. It also says the physical condition, and that's what you're treating with Botox and dermal fillers. But I would contend that Botox and dermal fillers is just like any other technology or treatment coming in. If it's in, it's in. If it's out, it's out. But if it's out because of aesthetics, then your porcelain veneers are out. It's no different. I mean, nowhere does the Texas Dental Practice Act exclude aesthetics for general dentists specifically.
Dr. Muckmuck, I'll cut you off. Dr. Henderson, any comments?
Thank you, Dr. Yu. I think we're a little bit out of order. Point of information, Mr. Chair. We do have a motion to allow legal to research just this topic, and this is not the forum to have this debate, in my opinion. Thank you.
Sure. Any other questions for Dr. Muckmucker? Ms. Nichols?
Not a question, but if he would like to submit any documentation to the board for us to review while we're going through the process, which the committee has tasked us with, we would welcome that information.
Sure, I'd be happy to. Thank you.
And we may invite you to our next meeting if if you're interested. Whatever comes out of this, obviously value your input on all this.
I appreciate it. I'm happy to help in any way. We work with every dental board, and we're happy to work with all of you as well.
Appreciate you. Thank you for your time.
All right, thank you. Have a good day, everybody.
You too.
Dr. Yu, we have one final public comment. It's Diane Rhodes with TDA.
Great, thank you.
There we go.
Hi, Diane.
Is it my turn? Sorry, when we get put in, it's so quick that it's kind of hard to know where we are. So I take it it's my turn?
Yes.
Okay. A couple of things. One, I wanted to clarify that TDA's rule comment letter regarding the proposed change to the minimum standard of care rule is in opposition to that rule proposal. It is not in support of it. The concern that the TDA expressed in the letter is that dentists have to be able to retain their flexibility of clinical judgment. And the association had concerns about singling out an agent within a drug class that has several choices and attempting to regulate around one specific type of drug in a particular class. And so I just wanted
Diane,
to.
I think you're talking about, are you talking about Halcyon?
Yes.
I think that's our next committee.
No, I'm talking about, oh, I'm so sorry. I'm so sorry. I thought, I'm so sorry.
We're still dental practice.
So sorry. Okay, well then this should be, at least my second comment should be pretty straightforward. My apologies for the first. Just to clarify, we were going to host a course on Botox and derma fillers during our annual meeting last year. Of course, COVID changed that. The position that we take with our instructors is that we provide them with a copy of the Dental Practice Act applicable sections and a copy of the dental board's policy statement. And we discuss that with them. And we expect them to share that information during the class so that it's very clear to the attendees.
That's great. Thank you for that. Any other questions for Ms. Rhodes, committee members? Ms. Jones.
Just to clarify, Ms. Rhodes, TDA was in support of the rule that we looked at.
Yes, I'm sorry. I got the sections wrong.
You're fine.
One was right.
Okay, good.
You can make another comment in the next committee. Okay. We'll hold you. Any other comments, announcements? All right. So do I hear, oh, Dr. Henderson.
Yes.
Okay.
The other person withdrew.
Perfect.
I was going to make a motion to adjourn.
Sure. Do we, Dr. Tillman seconds any, okay, let's take roll on that. Show of hands, motion to adjourn. Unanimous. Thank you, committee members. Appreciate you, and see you, Ms. Jones, tomorrow.
Thank y'all.
Thank you. The time is now 1:24.
Thank you, Dr. Yu.
Thank you.
Thank you.
Make sure you mute until next.
If you're going to stay with us, please mute. Committee member.
Henderson? They hear us.
They can,
There we go.
Hi, Dr. Henderson.
Hello, Miss Nichols.
How are you?
I'm great. How is everybody else?
We're great. We missed you guys.
I miss being there, you know. We got to get that hobby building open.
Oh, it's open. Now it's open,
Now it's open.
as of yesterday. Well, we're ready when you are.
Very good.
Have-
Where did Bobby go?
I saw-
Dr. McNeil.
Oh, well, I guess we'll.
And Dr. Yu, right? Are we missing
I was
David?
going to say, and I don't see Dr. Yu on my feed yet. Do y'all have him?
Nope, I don't see him yet.
I think we want to make sure we're not too early on Dr. McNeil. He doesn't like early mornings. Make sure this is late
It's
enough.
the crack of 2 p.m.
Exactly.
There he is.
Oh, good. He got his hair done.
This camp, my pain level's 1 out of 10.
Why do you have any pain? What's wrong with you? This,
Hockey, you know.
I don't know why I asked.
Oh, you know what? David just texted. He asked if I was able to get on. So maybe he's just having trouble.
You just went to the waiting room.
He's going to the
Okay,
wedding
he's
room.
getting on now.
Okay.
There he is. There he comes. Dr. Yu.
Still connecting, but I see him.
It says he's trying to connect his audio.
There he is. Okay.
He's online, it's just connected to the audio.
Dr. Yu. There we go.
Ah,
Hello. There you go. Okay. March 11th, 2021 Anesthesia Committee meeting of Texas State Board of Dental Examiners is now come to order. The time is 2:02. Thank you, committee members. I would like to remind you, if you're listening by a remote device, that you turn your speaker off or your microphone off until it's time for you to speak. If you'd please raise your hand, I'll do my best to recognize those as when we have discussion, to call on and try to have some kind of ordinarily recognition in this meeting. And do announce your name best I can, and you can as well, so we can record this virtual meeting the best we can as far as minutes. The mission of the Texas State Board of Dental Examiners is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. Ms. Nichols, would you please call roll to confirm we have a quorum?
Yes, sir. Dr. Brian Henderson,
Present.
Dr. Robert McNeil,
Present.
Dr. David Yu,
present.
Dr. Linda Berg,
Present.
and Dr. David Tillman.
Here.
We have a quorum. Thank you, Dr. Henderson.
Thank you, Ms. Nichols. Committee action number 3 on committee recommendation and possible action on data points the board staff can provide to the Anesthesia Committee on Dental Anesthesia, I referred to as the ACDA. I would like to ask Dr. Bell if she wouldn't mind leading this discussion to the committee. Thank you, Dr. Bell.
Yes, sir. Thank you. Basically, we have a lot of options here. I want to make sure that within statutory and rule guidelines, we're able to give the the anesthesia advisory committee what they need to in turn give you guys what you need. And so, you know, I believe there are a lot of different ways we could go. It could involve a little more manual staff work to give certain data points that you may or may not want, that may or may not be included in the DRP report. That is what the de-identified DRP report that now is currently within the materials that the Anesthesia Advisory Committee uses. So again, if there were any particular points such as ASA status as determined by DRP, specific drugs, doses, if there's anything else that we can give that will help, help us, help the committee to then in turn help you guys. Just wanted to open the conversation regarding that. There would also be an option if the board considered the state's resources worthwhile to do so, for staff to do a little bit different deep dive, again, at your direction. That would give you some other information that might be helpful. Our goal here is to keep the dental patients of Texas as safe as possible. So I want to do what I can, and staff in general wants to do what we can to help make that happen.
Thank you, Dr. Bell. And I can certainly want to thank you for working with this committee for the last couple of reports. And maybe we need more data, more patients, which I hope we never have any more patients, but I appreciate this. I'd like to ask Dr. McNeil, he raised his hand. He had something to say. Thank you.
Terrific. Thank you, Dr. Henderson. Dr. Bell, how substantially different is the data that you're providing to this group versus the Blue Ribbon panel? Is it about the same amount of data sets, or has that been kind of modified as this has progressed?
I would say extraordinarily different. And setting the expectations may be part of the situation here. We are limited in the statute. It's perhaps Ms. Studdard can read the statute and the rule. I don't have that in front of me, but essentially it's only deaths and severe complications essentially that they're allowed to look at. And then within those parameters, it is de-identified data that essentially PVE is queried, and then also our other system, Bursa, is queried, and then we compile that data to meet the ticks of what the statute specifically asks us to provide. Again, there may be room to provide a little more, a few more specifics, again, in a de-identified way, if there are things that, all 3 of 4 of you, or actually four of the 5 of you have all been DRP members before. So if there's anything that you might not have included in your DRP report that could be made into a data point that you would then want the Anesthesia Advisory Committee to analyze, then we perhaps could put a little staff time into that. Again, it would be more of a manual review, but we could do that and then provide more so like Blue Ribbon panel, a little bit more to that style of data. Now, we're still limited that, something, an occurrence needs to happen that is fairly substantial. So that doesn't allow us to analyze perhaps things that resolved in the office, maybe the stats dropped with a certain dosage, or so many things can happen, but that doesn't allow us to analyze those types of cases, which I believe would have been included in your Blue Ribbon panel data, because we were grabbing as many as we could for that. But again, the legislators have guided us on what we can grab for this purpose of this committee. So I think separating the two, what they had to work with and what they can generate, is important.
Thank you. Dr. Yu actually had his hand first, and then we'll get Dr. Tillman.
Thank you, Dr. Henderson. You know, I appreciate all your work on this, and I really do like, you know, the changes you put forth. You know, in terms of the blue ribbon panel, not we're going back to it. I know there was a lot of data points that you specifically had to look through the patient's charts and the records rather than just the DRP report. And you know, I'm just kind of wondering, like, you know, on like 1B or B1, for instance, you know, ASA type is identified, but I think it's almost more valuable to kind of find out what made the patient ASA 3, and you know, and whether a medical consult, for instance, was obtained, and what actually caused the incident. Like, is it an episode of apnea or you know, other contributing comorbidities that contributed to the mishap? Because to say that the patient desaturated or had respiratory depression and had to go to the hospital, I mean, it's almost like these sort of question marks that I know as a board member, we want to compile that kind of data as to like why this happened to certain patients. Like, for instance, why this patient was a ASA 3, you know, whether they were on anticoagulant therapy or, you know, in what ways were they medically compromised. You know, I don't know if that's too detailed, that we are kind of driving ourselves crazy over, but, you know, just kind of wondering that through the chair, if you don't mind.
Thank you, Dr. Yu. Dr. Tillman?
I would just echo some of the communication from Dr. Yu. You know, BMI, you know, over 27 or 30, you know, so that we could get better information. Melanopody, if it was higher than 2 or 3, you know, those kind of situations where the numbers were a little bit skewed. It would be helpful to know those as a part of the evaluation process from the Anesthesia Advisory Committee. And I know you're doing that to a degree, and I don't want to put any more work on your plate than you already have, but all that information to me is relevant, kind of like Dr. Yu stated, and is helpful. You know, typically it's like a car accident. A car accident is not typically 1 or 2 issues, but it was a domino effect of issues, and then there was one final issue. And a lot of times that happens with medical issues. It was not just one issue, but it was a cluster of issues that culminated in an accident or in an unadvisable situation, an outcome. So just to echo Dr. Yu, any kind of data that gives us light onto the reason for the accident or a bad outcome is helpful. Thank you.
Thank you, Dr. Tillman. Dr. Bell, would you like to address those couple of comments, and we'll go back to Dr. Yu?
Absolutely. I couldn't agree with you more. You know, again, I would look to Ms. Studdard to tell us if that is allowed under our guidance. And then secondarily, you know, look to my ED and as well as the board, and just determine how much staff time, you know, we can devote to this. And thirdly, you know, I am so glad this is on the agenda, because I am, you know, if I'm to do it, I'm happy to do it, but I am looking for a list. You know, what is your list? So that we know we're meeting your expectations, passing that along to the Anesthesia Advisory Committee, and then in turn, hopefully them having more data to process will provide a final report that is a little more detailed, which seems to be, you know, what y'all are hoping for.
Thank you, Dr. Bell. Dr. Yu?
Well, a couple things I just remembered that I remember the original Blue Ribbon panel had portability in it, whether the person, the licensee actually used their portability in that mishap. And also EMS, where whether there was an EMS delay or inappropriate emergency response. So I think the more data for usually when there's a mishap, there's multiple things that happened. And I think what I'm trying to say is that we want to know what the multiple things are. And a lot of it is just kind of obviously looking through the DRP report, but, almost diving in on what was done that could have contributed to the problem.
Thank you, Dr. Yu. Dr. McNeil.
I'd be remiss if I didn't complain about prior anesthesia committee reports that were given to us. And my complaint was a lack of detail. And I can appreciate there's statute there, but I'll harp on, length of the procedure seemed to be an issue. We have no idea what that means as a board. And for you, Dr. Bell, you're kind of the go-between with all of this, and I can appreciate how we want this committee group to have access to detail, to formulate things, to send it to the board with some actionable data. And I think they have more data than they're sending our way. And I think obviously there's a legal review of that. And I'm going to keep pushing back on what I see as just a lack of detail. So I don't know if we say, okay, here's some items that we want in your Excel spreadsheet that for you guys to pull at the end of the day where the rubber meets the road and we're trying to make some decisions on that. Are we going to get that data? So I don't know. I'm kind of at a little bit of a loss other than I'd push it to you, Dr. Bell, and say, what do you think they need that they're not getting?
Dr. Bell.
If we're going to compare it to Blue Ribbon Panel, which I believe is inevitable, you guys actually had a continued conversation. So you were introduced to the data, you had some time with it, you had some time with each other, you went away, you had some time to process and kind of cull through that. And then you all came back with additional ideas. And it's just happenstance, the way that it has worked. But with just the one meeting, they get the data in advance, but just one meeting to kind of mull those minds together and, just kind of like the think tank type of deal, and then needing to kind of come up with their opinions. I believe perhaps even if there was just one more meeting added, where they had time to analyze the data, come together, discuss, then have some time with the data, and then come together and discuss again, and perhaps workshop the report together that day. There may be some different options. That's one way that it's different, that perhaps y'all were able to come together in a different way. In terms of data points, I'm with you. What we'll all need to understand is some of these cases are lacking these data points, and that's why they perhaps got a board order or remedial plan. So Malampati, for example, isn't always there. If sometimes they haven't even tracked respirations or vitals, SpO2. So we have to understand that those points won't be there necessarily for every single case, because sometimes that's the reason things went bad. But again, if I'm given a list and I am given the time, I will do whatever I can to help with this situation.
Thank you, Dr. Bell. Dr. Yu.
Sorry, Dr. Henderson. Did you want to say anything first?
No, you go ahead.
I'm sorry. are we talking, are you recommending another, like a second meeting, like 2 meetings a year? And maybe that first meeting can be just to go over cases, and maybe even Zoom. And then the meeting after that would be sort of the, culmination of analysis and, evaluation of those cases. Through the chair, please.
Oh, I thought that was the question to Dr. Bell. Dr. Bell.
Thank you. It's just an idea. It's just a difference that I've identified between the systems process of Blue Ribbon Panel and what we've had going on with Anesthesia Advisory Committee. We may, there are all sorts of reasons that we did it the way we did it, and that may be fine. But there's just a little bit more having processed a lot of this kind of data. I can tell you from my experience, sitting with it matters. And then, you've got the filters, sorting it different ways, different trends come together. But it is difficult to do necessarily by yourself, and we want all those great minds with all that different specialty experience to come together and really mesh. And again, without a little time after that first meeting, that may not happen organically, shooting emails back and forth or just alone processing the data. So I'm not necessarily advocating one way or another. I'm just identifying that that's a difference, that just our human nature and our need to process might be beneficial to have another meeting.
Dr. McNeil.
And I fully support what you're talking about there. And I think part of it is individuals getting a perspective of the data, getting an appreciation for the other individuals in the group as well. And, I commend you once again. You're the go-between on this, and you're from connecting us to this group. So and I guess this is a question through the chair, what do we need to do today at this meeting regarding this issue?
Oh, well, I think we're still working on that. I don't know that it's within our purview to be able to change what's in statute and what's in rule. The rule is in your packet. I think it's more of a communication with Dr. Bell. I mean, and to have this discussion, because we've had 2 Blue Ribbon Panel members on this committee that know what they want, but we really may not be able to give the same data point and tax the agency to dig in that information every year. I go back and I look at the number of cases, and we've maybe had 60 cases over the 2-year reports that they've looked at, which still aren't very many numbers. And granted, that's the first time they've done it. Now they've done 2. We're going to have probably some committee members that roll on and roll off the committee. Just like if you could imagine the Blue Ribbon, you finally understood what your charge was, and you got the data, and you finally got where you wanted to be, and then half of you left and 2 new people come on. So we're going to have to be a little patient, understanding that we are gathering the data. I might recommend that we do like a 5-year kind of a recap, and maybe every 5th year after they've spent, maybe it's a 2-time meeting. I like the idea of a 2-time meeting. One of the time is to look at the current data, and the next one is try to put all 5 years together and pull out that meaningful data on that second meeting to see if there's some trends, because if you're just looking at a snapshot from year to year, you probably don't see what happened the year before, especially if you weren't on that committee, so you had no idea what the committee saw. And I would also pitch to Dr. Bell, people are talking about what is needed, what is data. Maybe we need to have as a DRP member myself, maybe we need to have a DRP check sheet I know y'all went to paper vision after I left, and there is a form that y'all use. And maybe that's something that the DRP person can put in their report. And if it's not there because they didn't use CO2, they just say, didn't use it. And that information, then Dr. Bell's not trying to dig through these records at the end of the year, or someone in her staff is trying to use resources, that it's something that the DRP person could actually populate when they do their report prior to writing the actual report. Because if you look at what's in the rule, I think the information that is supplied by the DRP report and the information that's in rule is enough information for you to gather. If we could give that, and if we wanted a specific detail like weight, it's not on there. So we could just say, we want the patient's height and weight, which if we want to calculate, or they want to calculate BMI, they could on a case if they see trends, rather than asking the agency to use our resources. But that's my thought as I hear this discussion. Any other committees members have a thought on that? Dr. Tillman?
Thank you. Just a quick thought. To prevent incurring too much expense to the state, we could have one of the meetings, a virtual meeting, still share data, still have work from the staff, and kind of use that without incurring too much expense on the state. So just to keep that within the box of thinking, so that we don't, hike up the price too much. So just a thought.
Well, I do think they've had virtual meetings this past year, so they may continue to do virtual. And it shouldn't be us to say they have to be in person or virtual,
Right.
or one or two. But it's still, if you have a meeting, it's time of resources of those people who have to run it and put it together. So whether it's virtual or there, I'm going to kind of leave that for the agency, in my opinion, on how to set that meeting up and what is the best for them. Dr. Yu?
So is that sort of the up to the AAC chair's decision as to to hold extra meetings, or is that, I know in statute they have to have one a year.
Right, Dr. Yu, they have to have one a year, but we can, Laura and I'd be happy to reach out to Dr. Masters. She's the current chairman of the committee, and get her thoughts on doing maybe their last meeting was virtual, that's true, but doing one meeting to the initial discussion about the cases they've looked at and reviewed, and then maybe the next meeting actually formulating just to have more time with the data, like you're all suggesting.
Dr. Yu, yes.
I think Dr. Bell had her hand up first.
Oh, Dr. Bell.
I was just quickly going to ask, probably Ms. Studdard, if she felt the statute gave us room to provide cumulative data each year, as in the data set would get bigger and bigger and bigger, or are we limited to that previous fiscal year and the data associated?
I don't know if I'm understanding your question, but
yeah,
the data that they're required to review is in Rule 100.12. We can suggest additional data, but they're not required to under the rule.
I think the question that Dr. Bell was asking, what they get each year was what happened the year before. And she was wanting to make sure my suggestion of saying maybe every 5 years when you get enough cases to look at trends, could the current committee look at that old information and create a report? I don't want to misspeak what Dr. Bell, but I think that's what you're asking.
Did you have it? I was going to make a comment to that effect.
Ms. Nichols.
So in reviewing the rule, I think that the rule tasks the agency with collecting the information for each year, right? But there's nothing in the rule that speaks against a compilation approach that you're suggesting every 5 years, that sort of thing. But that is absolutely something we could take up with, again, Dr. Masters, the committee chair, and gauge her interest in that, because ultimately it's their committee.
Right. So that was kind of the way I read it, but I didn't want to be legal. But and to me, the interesting point was we have this obviously in some kind of form, digital form each year that's submitted to them. So the 1 year on that one meeting, even if it's in person, you let them look at it. But I'm going to leave that a little bit as long as we can make the 2 blue ribbon panel members on my committee happy with some kind of output data, then I think we're making right steps. And I'm going to ask my committee to be a little bit patient because this is a learning curve and it's something new, and it's not going to be as detailed at the number of hours that they spent getting you all the data that you looked at for the blue ribbon when we went through sunset. Dr. Yu.
So Dr. Henderson, moving forward, can your committee members submit data points that we can put together that's ideal, and we can kind of look at the like for our June meeting, look at just kind of a list of our wish list, if you will. Like for instance, local anesthesia. There's nothing on it with this, and there were 8 cases with that in the last report, and we want to know like overdose, toxicity, syncope, hematoma, needle fracture, para or anesthesia, intravascular injections, seizures, respiratory arrest, or just pain in the injection site. So, there are a lot of things that were said that, there's a, issue with local anesthesia, but, like I said, is there like a way for us to submit our wish list and have Dr. Bell and, the committee members kind of vet the data points?
So you make a great point, Dr. Yu, and my interpretation is they are already given the DRP report, and the DRP report, if there's one of the accusations is they overdosed this patient with local anesthetic, that's something that the committee has the right to review. Now, if they're not taking that information and generating us a report that we feel is helpful, then that's the information. We don't really need to get into a list. Now, I'm happy to get into a list, but I would ask you to look at what's on there. And if we feel that the DRP report, we want to have some kind of checkbox, we'll ask Dr. Bell, see if she can put that in a checklist for the DRP report. Because we all know the report's only as good as the DRP person has written. Dr. Bell.
One complicating factor, changing the worksheet, excuse me, at the fiscal year is certainly possible. Clearly, when we query that data, it'll be null values for any older cases, and then the newer cases will have a value. However, again, we're not quite winding down for this fiscal year, but we do need probably more of a manual solution for this fiscal year that we're almost done with. And then we also could look to the future on what would be most judicious with staff time and asking DRP to fill out a little bit more on that worksheet. But again, understanding that if we ran the data in a cumulative nature, 2017 is the first data we would have in paper vision. But if we ran the data in a cumulative nature, we would have a lot of null values for the older cases, but then moving forward, we would have that completed. And I believe, and I would ask Chris if that would create any problems within the report that he has built to query PVE. But those are some tech things we could work out. But yes, understand that we do have a lot of cases that are already completed for the fiscal year that will be coming up for review.
Dr. Bell, do you feel that the ACDA committee is given enough information to generate a better report, or do you feel that the report they're generating is about as good as they can get without more information?
I would say comparing it to Blue Ribbon Panel with what we've given them so far is a mistake. I would say, we have an opportunity, if we have room in the statute and rule, to give them a few more points that they can play with on a spreadsheet. Our DRP members are amazing, but try to get 100 people to write a report in exactly the same way. It's just not feasible, so I would say that, we can find a balance with some guidance from the board, as long as we are still working within that guidance from the legislature. But I would say it's not apples to apples, and that's what's important to recognize. But then we can still move forward in a way that works for everyone.
Do you think there's some value that we sit back and just wait and see how this progresses with time in the reports, rather than knee jerk? This has only been in operation now 2 years. We're the only state that's doing this and releasing it. And do you think patience prevails?
I would leave that to the expertise of the committee and the chair. I believe 2 years, it's not necessarily enough data to have, eye-opening revelations. But if we're seeing that there are a couple things that aren't necessarily consistently found in DRP reports that a little staff time could generate, we're not talking about thousands of cases, we're probably talking about 50 cases, 60, 70. That's manageable, especially if we get a jump on it and are able to do it throughout the year.
You look at most of these cases, yes? You see most of these cases.
In one form or another, yes, sir.
And do you feel that, can you identify that a DRP, there's something that you felt the DRP is consistently missing amongst them?
I guess what I would say is different items are important to different practitioners, sometimes within specialties and sometimes just various people. We're human. And so, again, I like your idea of altering the worksheet or giving them specific items to fill out. And until we get to the point where the worksheet is populated for all the cases where we can do a query, again, if given direction from Casey or whomever, I'm happy to do it manually. Again, if I have targets, and then I've got sense enough to summarize outliers, or if there's something extraordinary that happens with local anesthesia, as Dr. Yu was stating, I can write little brief summaries that might be a little different than what DRP wrote, but still with the data. So, we have a lot of options. We just basically need guidance on, how we can do what helps you guys, as well as the dental consumers of Texas.
Great. Thank you, Dr. Bell. Dr. Tillman.
One more quick point is, as a rep examiner, we spend a lot of time calibrating, and just to kind of look at things that we're supposed to evaluate and kind of review of previous cases, previous exams, that might be a consideration. Maybe look at some old cases and getting the board or the advisory committee to look at those and individually evaluate data points and just the whole scope of the incident, and kind of spend a session to kind of get everybody on the same page. Even develop a template through your worksheet so that everything that is important is at least looked at. So just one more suggestion there.
Thank you, Dr. Tillman. Dr. Berg, welcome.
Hi, thank you. Dr. Bell, I did want to just kind of reiterate that I think I love your idea about the two meetings. That's going to really help. But going back to altering the worksheet, And what Dr. Yu stated about knowing exactly why the patient, let's say, is an ASA3, I think what's also important is to include things about, was there like the medical consult, appropriate medical consults, was there good communication between the licensee and the medical provider, things of that nature too. And the thing that I love about altering the worksheet is because it will standardize all the reports a little bit better. And that way we know, was it just omitted by the DRP, or was it just not included in the information that they were given, as far as the licensee maybe didn't take away or look at the size of the tonsils and determine the Malampati score. That's all I have.
Thank you, Dr. Burke. Dr. Bell?
Yes, absolutely. I mean, we would want the Malampati, yes, that would be able to be there. You know, what happened with the adverse local anesthesia event, it's going to be really hard to make that into a worksheet queryable item. But again, we would expect that to be in the DRP report. And again, if I knew that was on your list of things that you wanted, I can manually check that. You know, I don't think we're going to be able to get away from at least a little bit of manual checking if there are key things. But, you know, enhancing the worksheet is a very good way to increase that data set of de-identified data.
Thank you, Dr. Bell. And I'd like to point out to the committee members that if it is a local anesthetic case, you're not going to have a Malampati requirement, because we don't have it in our rules for every dental patient to have a Malampati evaluation, only until you get the preoperative checklist. So that in itself is going to eliminate some data if we're speaking about local anesthetic only and Malampati. So part of our rules, because as you progress in the anesthesia, they become more capturing. It makes it difficult to have a standardized data point on that worksheet if it only applies to level 3 and 4, or only level 4, or only level 2, 3, and 4. So as our licensees have these problems, that makes it more difficult, which might make it more cumbersome for Dr. Bell. But I think it's an easy way if we could come up with either a few ideas that may be applicable in all categories, and maybe ask the DRP to point out if it is a drug overdose, put it in the report. If it is a lack of medical consultation, put it in the report. I mean, everything they write in that report is given to them. So, Dr. Yu.
Well, this is a question for Dr. Bell through the chair. You know, so I think what we're really looking for is just relevant data. I mean, obviously, you know, every patient that has sedation should have a Malampati, hopefully. But, you know, like, for instance, I'm still confused back to the local anesthesia issue, because, you know, what are they looking for, in other words? Because if the DRP says, oh, there's an adverse event, does that mean that the dentist put in too much anesthetic, but there was no issue with it? Because I know the standard of care sometimes says, oh, the dentist or the respondent administered 13 carpules of lidocaine, and that's above the, you know, recommended dose, and overdosed it, but there was no consequence to it. Is that an adverse event, or was there physically an adverse event?
Dr. Bell?
In a way, well, okay. So on the worksheet, DRP has to address whether the patient was given local anesthetic and if there was a complication with that provision. So that's local anesthetic, that's nitrous, and that's sedation or general anesthesia. So what happens is, with the query, it will grab that case if they say local anesthesia and yes, and then we would expect the report to elaborate on it. Could the report not contain a violation on local anesthesia and there still be a complication? Of course. As you know from your experience, there's a little more meet to a violation report than a non-violation report. Clearly, we can have adverse events and there be no violation. So again, I like the idea of the worksheet and ticking off at least few important points that maybe won't apply to every case, but would be more easier to identify the trends. Does that help or answer your question?
I think so. Thank you.
Dr. Bell, not to put too much on you, since you read these reports, you see the DRP reports, you hear the sentiment of my committee, and you understand what the worksheet purpose is, do you think there's some data points in your mind that might be advantageous to add without having the committee determine the next time to get together and have a committee meeting to come up with data points? Or do you have a suggestion that you could think about that might be workable?
I would prefer to have a preliminary list to work with. But if that isn't in the interest of time, again, we're cruising closer and closer to the end of this year's data set. So I'm malleable. But yes, I was hoping to leave here today if you did want more data with a list of things I could at least go get, or maybe in the future we could query DRP a little bit more when we have more time.
Thank you. Thank you. You answered exactly the way I figured it would. So I'm going to ask the committee, does anybody have any motions or anything? We're going to go on to the next topic. Dr. Yu.
Off the top of my mind, can I give you a preliminary list?
Yeah.
So obviously I mentioned, if a patient has ASA3, we want to know why that patient was ASA3 in general terms: cardiovascular, uncontrolled diabetic, morbid obesity, whatever. Another thing is portability I mentioned, because portability, we want to know if ideally, if their license was used in these situations. And really EMS, for instance, I mentioned about the emergency response, if that was delayed. That was part of the Blue Ribbon panel, metrics also. Local anesthesia, I mentioned about exactly what the adverse event was with local anesthesia, previous board history, whether there is a pattern here of issues. And I don't know if that violates the de-identification, but I think as board members, we want to know if these people keep repeating the same issues. I think that's all I can think of. Thanks.
Thank you, Dr. Yu. I just wanted to point out we've removed portability out of our rules, and so that's why it's location in the rule. So I think I'd ask you to rephrase that to say location of anesthetic as opposed to whether the person was portable or not.
Yeah, location. Thank you.
Thank you. Dr. Bell.
Yes, and that is in the data set that is pulled from the worksheet that DRP does complete. It will say in the respondent's office, in another dentist office, or in a surgery center or in a hospital.
Okay.
So that is already in the data set.
Thank you, Dr. Bell. And that's why I wanted the committee to look at the rule, because that's what they're given. And if that's the information you want, that's already given to them and they're not giving it back to you. So that goes back to, what is it? Are we trying to reinvent the wheel and give them data that we're not getting back? Or we need to say we'd like to have that categorized in the report as well. So in a way, I don't want us to get off track on what we're really trying to accomplish here. Dr. Tillman, you had something you wanted to say.
Just to continue Dr. Yu's list, BMI would be there, Malampati, duration of case, age of patient. Those kind of issues might be thought of as to be added if they were out of the ordinary. Thank you.
Dr. Tillman, I can appreciate that. And BMI would be something that the DRP person would have to calculate because our rules don't require BMI. We have height and weight as our rules.
And that's fine
So,
too. Sure.
Thank you. Dr. McNeil.
And I concur with Dr. Henderson's comments there. I think they're getting the data. It's a matter of what we're getting back. We're listing out these data points, length of the procedure, for instance. I assume that's one of the data points they're getting since that was one of their strong areas of concern. But once again, we got no goalposts on that. So.
Yeah, and so to what Dr. McNeil's saying is that, for example, long cases, well, what is long? It didn't say long cases 90 minutes, long cases 45 minutes, long cases 2.5 hours. So part of that in the report, maybe being a little more specific when they write the report so we can actually see exactly what they're saying. Now, I don't want to misspeak for Dr. McNeil. Dr. McNeil.
And I feel exactly the same way. And this is my push on legal to look at situations. And if we have 5 cases that this committee has deemed as these are long cases, we had 5 cases ranging in time from 4 hours to 8.5 hours that had negative outcomes. That's the kind of information we need as a board because, it just doesn't give us goalposts.
Thank you, Dr. McNeil. Any other, Dr. Yu?
Sorry, and I know one of the report, the previous report talked about, not the last report, but the previous one talked about polypharmacy. And I would love to have sort of more details on that, not specifically what drugs necessarily were used, but, whether it was inhalational agents used, oral and IV sedation, multiple oral sedation agents, or, medications used. Just a little bit more on that would be also helpful for us. Appreciate it.
Thank you, Dr. Yu. I'm going to ask Ms. Studdard, are we out of order for submitting this list without a formal motion? Or do we need to make this as a formal motion or just direction to agency and Dr. Bell?
I think it's okay not to do a motion.
I would take it as just direction. I don't think.
Thank you. I'm getting a little nervous on where we were going with this meeting. So, okay. Any other committee members, any other comments for Dr. Bell? Thank you, committee members. Thank you, Dr. Bell. I appreciate your time. I would like for you to stay close by though. The next item on the agenda is committee recommendation and possible action of currently proposed rules from December 11th, 2020 board meeting. 22 Texas Administrative Code 108.7 Minimum Standard of Care General, published in the January 8th, 2021 edition of the Texas Register. Ms. Studdard, would you lead the discussion on this proposed rule?
Yes, sir. So as you mentioned, this rule was up for proposal at the last board meeting. It's now up for adoption. It's 108.7 concerning the minimum standard of care. The amendment requires dentists to hold a level 1 minimal sedation permit to administer Halcyon or triazolam, and provides that dentists should administer Halcyon in an in-office setting. And so the board has received 3 comments after the proposed rule was published, and I'm going to go over those with the committee. The first one was by Dr. David W. Canfield. He provided a written comment in support of adoption of the rule as proposed. Dr. Canfield stated triazolam, although classified as a benzodiazepine, is unique in that it is classified entirely as a sedative hypnotic by the manufacturer and the Food and Drug Administration. It is not labeled as an anti-anxiety, nor is it purported to have any anti-anxiety properties. Dr. Canfield stated classifying medications and their proper use is not overregulation, but rather an important safety aspect. He is aware of practitioners having incidents that have occurred after patients consume triazolam, including patients who were involved in motor vehicle accidents and a patient who fell and was injured. Additionally, patients arrived medicated to the office, and it was difficult getting them into the office safely. And some patients have been dropped off without a designated driver or without appropriate post-sedation supervision. Dr. Canfield stated it is a dentist's obligation to assess if the patient is in appropriate condition to be sedated on that particular day, which means current vitals and auscultation are imperative prior to medicine intake. The board also received a written comment from TDA, who is in opposition of adoption of the rule as proposed. TDA stated that the board should not become overly prescriptive via rulemaking in a manner that interferes with dentists' autonomy, such as identifying and regulating specific drugs in rule, unless there's a data-driven patient safety need to do so. In the context of patient safety for anxiolysis, dosages and patient selection, not drugs, determine safe outcomes. TDA stated identifying and regulating a specific drug and rule will not improve patient safety. Dentists can simply choose a different drug in the same drug class, but there are several from which to choose. If the board has data documenting patient safety concerns with the administration of certain drugs for anxiolysis, TDA stated a more concrete and direct approach would be to review the definition of anxiolysis, the Texas Occupation Code, section 258.152. TDA stated dentists do not need a sedation permit to administer anxiolytics and analgesics in the context provided by the statute. The third comment we received was by the Texas Academy of General Dentistry. They provided a written comment in opposition of adoption of the rule as proposed. Texas AGD is not aware of data or evidence of patient morbidity or fatalities attributable to the prescribing or administering of Halcyon for anxiolysis. Texas AGD stated there are existing regulations dentists are required to follow for standards of care for all drugs, whether prescribed out of the office or administered in the office. Should the board move forward in adopting the rule, Texas AGD suggests changing it to either clearly allow Halcyon to be prescribed for use at home or give clear guidance under which conditions a dentist may prescribe it for such use. Texas AGD is concerned that a rule requiring a dentist to have a level 1 permit to prescribe or administer Halcyon may have an adverse impact on patient care, since dentists will have one less option for special needs and other patients who have anxiety about treatment.
Thank you, Ms. Studdard. Dr. Yu.
I'm in favor of Halcyon being only for level 1 and above providers, because, you know, obviously level 1s have some basic training, you know, and hopefully they have oxygen, they have emergency equipment to be able to manage any issue. And I am not in favor of, and just for the record, and not in favor of, you know, only allowing Halcyon to be administered in office. And, you know, driving under the influence, for instance, with Halcyon is an informed consent and poor judgment problem. It's not a problem with drug administration. I mean, we can't force a doctor to prescribe a certain way, in my opinion. And nowhere in our rules do we tell doctors how to prescribe. This is a whole new field for us. I mean, we do ban certain substances, like certain sedatives, to not allow to be prescribed, you know, by under level 4s, obviously, but we don't tell them how to prescribe. And I just think it's a unnecessary overreach over an issue that really has no evidence of being a problem in terms of public safety. I mean, to me, it's not the problem of the pharmacokinetics of the drug, because if something happens, it's the problem of informed consent. You know, so admittedly, I rarely do oral sedation myself, but I'm not going to tell a doctor how to prescribe. And if something does happen, I hope it's you know, under ACDA's caseload, that they can actually have some justifiable information for us to make a rule on. So for now, I just feel like we're trying to make a rule just to make a rule, which to me is overreaching and overregulating, in my opinion. I don't like that idea. Thank you.
Thank you, Dr. Yu. Any other committee members? Dr. McNeil?
I guess this is a question for my fellow committee members. Is there anyone who hasn't seen a case of an adverse effect with a drug such as this being prescribed out of the office? I'm assuming based on your comments, Dr. you are not aware of any cases. I think we had talked about this beforehand and risks of driving while impaired with that drug. But does anyone denying that cases are? Because I know I'm familiar with several cases in Texas that it's been an issue.
So I know I'm as well, Dr. McNeil. Dr. Yu?
Well, I think we're kicking the bucket here. We're kicking the can because it's an informed consent issue. It's not the drug. So, what happens when we have other law of unintended consequences. We disallow Halcyon use. And all of a sudden they're going to prescribe Valium, which has a half-life of 20 hours, or Ativan, which has a half-life of 12 hours. And, whereas good old Halcyon is, hour and a half. And, so my point is that they are going to switch to a different medication and we're going to have the same problem. We need to focus on, informed consent and telling them, hey, these are what we recommend. And God forbid, if something happens, we're going to see them in ISC for it. I mean, so you can't blame a drug. I mean, Halcyon is a good drug for dentists that have level permits, especially for the length of time that we treat these patients. And the law of unintended consequence is the fact that, very few offices have operatories to let the patient sit there, while the onset in 30 minutes occurs. There is no ISC issue with this. That's the bottom line. And yeah, I've heard of cases, but it could happen with anything. That's my point.
Dr. McNeil, you had something you wanted to say.
Doctor, are you okay if I give a patient Halcyon in my office and don't hook them up to any monitors and take no vitals?
I am in anxiolytic doses, even though it's a sedative. But remember, the onset is 30 minutes to an hour. Okay, and the question is there public harm? You've only heard of cases where it's an informed consent issue. Are these patients being over sedated and they're dying in their cars?
So I think there's been some driving issues. There's been some falling and mechanical injuries with it.
Informed consent.
But so you just tell them, hey, don't drive, don't fall. The big issue, obviously, with any of these is if you combine it with opioids or alcohol. That's one of the advantages in the office. You have the advantage to eyeball them and make sure they're not pulling out their flask out of their coat pocket and taking a little supplement. And honestly, David, I hear what you're saying. We always want to be careful, certainly, of the law of unintended consequences, and we want to be mindful of overreach. As I've said before, it doesn't pass the smell test if someone gives it at home without a sedation permit, and then I give it in the office and I need a sedation permit and I need to do vitals. Well, let's scrap all that. If we look at it and say this is totally safe, most people are still doing that dosage, a 0.25 milligram dosage to do it at home. They may do that in the office as minimal sedation, and we nail them at an ISC if they don't have vitals and do their preoperative checklist and all that sort of thing. It just doesn't pass the smell test. Dr. Canfield, personally, I agree with his statement there. It's a little bit of a different beast drug, and there's certainly more issues with people getting in the vehicle and driving. I like the fact that this doesn't say they must give it in the office. I believe it's a should comment there. And if you decide, hey, I've done this before on the patient, or this is a reasonable and prudent thing that I think in my independent clinical decision-making that this makes sense, then we're not saying you must, it's you should. So then if there is a problem, then you have to show up at an ISC and you defend it. We really want to give, we want to give docs the ability to make safe choices. Part of, like, as you mentioned, some of these drugs like ketamine or propofol, it's classified as a different drug with different permit uses. So I hear what you're saying, but once again, I don't think we're at the point for anyone to say, well, let's stop requiring monitoring in the office for this drug. So why are we doing it out of the office?
Thank you, Dr. McNeil. Dr. Tillman.
Yeah, I hear you, Dr. McNeil. I would tend to support Dr. Yu. I've gone over the drug. I've gone over how to take the drug. We give the prescription. They're supposed to fill it. They're supposed to come to the office, and then they're supposed to take it. Now, have I had patients take it before they come in? Yes. I had one patient drove themselves. Couldn't believe it. We had it well informed. They signed the consent. So I agree that the issues that we've had have been informed consent. They're just not following what they signed. Can you make them do that? No, particularly with a drug that's PO. So I would tend to agree that a lot or most or all the issues that I've seen in my practice have been lack of patient compliance with the consent that they signed. Thank you.
Thank you, Dr. Tillman. So before we get any further in this discussion, I just want to ask a question to the committee. Did everybody look at their materials? Did everybody read Dr. Bell's report? Okay, so I don't want to hear where there's been no reported morbidity, mortality with this drug. So if you read her report, it's pretty obvious that it's not just someone who didn't take their informed consent and drove their car. Okay, so these are data of cases that we have and see. So I want everyone to realize that this is since 2017. It doesn't even go back to the cowboy days when we gave Halcyon like candy. So I want to continue on. Dr. Yu, you had something you wanted to say.
Well, I would like to encourage licensees to use Valium and Ativan instead of Halcyon to have patients take it at home. I'm being facetious because really there's a drug, Tezolam, you may know about it, and TDA referenced it, where it's a oral or sublingual. The duration is 5 to 7 hours, but it has similar onset to Halcyon, but it's a sedative and muscle relaxer. And if I were doing a Halcyon, administering or having it taken at home, I'd wait for that drug. So, which is more dangerous? I'm saying that our real issue is informed consent, and that's covered by our board rules, 108.7, and every single chapter of 110 in the pre-procedural preparation. So informed consent is what we should be focusing on.
Okay. Thank you, Dr. Yu. Dr. McNeil.
Respectfully, Dr. Yu, what do you mean about informed consent? Just saying to the patient, hey, here's how I want you to take it. I don't want you to take it with alcohol. I don't want you to take it with opioids. I don't want you to drive. I want you to hand the keys to someone. We just had Dr. Tillman talk about one of his own cases where, despite informed consent, there was a challenge.
Well, can I talk, Dr. Anderson?
Yes, you may.
So, we're going to get rule breakers. Let's prevent people from doing wisdom teeth, because of the 1 or 2 cases that we'll see, each of us that has paresthesia, anesthesia. So we should keep everyone from doing wisdom teeth. How's that? So, my point is that there will be people doing, rule breaking, and you can't destroy an entire industry. And literally, this is going to affect a lot of people and their ability to give access to care by passing this thing.
Dr. Yu, I would disagree with that statement. We're not eliminating all benzodiazepines from the anxiety class. We're eliminating a sedative that is being used as an anxiolytic into a sedation rule. That's all we're doing here. That's all the rule is that's proposed. It's not saying you can't give Valium, can't give Xanaxes. The thing is, no physician administers Halcyon outside of a hospital setting because it's not an anxiolytic. In reality, it really should be considered a level 2 drug because it's not an anxiolytic. We have to realize a level 1 permit by the ADA's creation is supposed to be anxiolytic. In order to give Valiums, Xanax, or any other drug in any other state, you have to have a level 1 permit. You have to have the 16 hours. Texas is unique that we allow our practitioners walking out of dental school with no additional education the ability to write the same drugs a physician would for an at-home drug. Halcyon is not that drug, never has been. We have had people that have gone before us that had no permit that adequately and massively overdosed patients. And part of that is in what you see in Dr. Bell's report. But other ones went to SOA. So I think we have to sit back and think, what are we trying to do here? Because when Dr. McNeil first started this, I was like you. There's not really been a whole lot of problems. But as I've dug into the cases and realized that Halcyon in itself is not an anxiolytic drug, just like Rohypnol, it's a benzodiazepine. It's not an anxiolytic drug. You can go to Mexico and get it. Can't give it in Texas. We regulate ketamine for a level 4 only person, but kids use ketamine all the time on the street. That doesn't mean they have a general anesthesia permit. It means that it's a drug that people use, and that's the reason dentists like it, because it's amnestic. Great. If it's amnestic and sedative, it needs to be controlled. Dr. Yu.
I'm not questioning whether Halcyon should be level 1. I think it should. I think that, level 1s have hopefully the training for emergency situations. But just that, for the record.
And so what Dr. McNeil is saying, it doesn't mandate that you give this drug in the office. If we encouraging you to give it in the office, if you choose to give it out of the office, as Dr. McNeil says, and you have a bad outcome, you can come in front of the DRP or an ISC, and we'll just evaluate that and plead your case. It's not a must, it's a should. I'm in support of this rule as published and adopted, but happy to continue this discussion. Dr. Tillman.
Call the question, please.
Is there a second?
I'll second.
All in favor of calling the question by roll? Dr. Burke. Dr. Burke.
In favor.
In favor. Dr. McNeil.
Against.
Against. Dr. Yu.
In favor.
Dr. Tillman.
Favor.
Dr. Henderson. Against. Motion passes.
Roll call.
And what is the question? No one's made a motion to adopt this rule.
There should have been a motion to begin discussions.
Well, there should have been, but I thought Dr. Yu was going to make that motion, and we've gone way off the top.
Thank you.
So, point of information, we don't have a question to call, but okay. I'm still waiting for a motion from the committee. Or discussion. We're in discussion, right?
Point of order.
Yes, sir.
So my motion to call the question was out of order because there wasn't a motion.
True.
Or I will make a motion to accept Administrative Rule 108.7.
As published in the register.
That's correct.
Thank you, Dr. Tillman. Is there a second? Dr. McNeil? Second. Roll call in favor of calling the question. We're going to make a motion. We got a second. Dr. Yu?
Against.
Dr. McNeil?
Point of clarification, this is a call to question, or this is?
No, we're voting on the
In favor.
Voting on the nomination. Yes.
In favor.
Dr. Burke?
In favor.
Dr. Tillman?
Favor?
Dr. Henderson is in favor as well. Motion carries. Dr. Yu against. Thank you, committee members. Do we have any public comments?
Yes, sir, we do. We have two.
Yeah, we have Diane Rhodes and
Dr. Canfield is on the line. I believe he logged in first, so if we could, we'll get him queued up to speak to you all.
Give us a minute. We're getting him.
He's online. Looks like his microphone's muted.
So he should be up. Dr. Canfield. Dr. Henderson, I think he's up.
Yes. Dr. Canfield?
Yes.
Thank you for joining us today. Please limit your comments to around 5 minutes. You have the floor.
Okay, hopefully.
We lost him.
I'm here.
Oh,
okay. Thank you, Dr. Canfield. You have the floor.
Thank you. I appreciate the work that all of you are doing on the committee. However, it turns out I'm impressed. I haven't sat in on one of the meetings before, and it's a great thing. I do have a couple points I would like to make. One, when they refer to it as anxiolysis, again, I have to reiterate, it's a sedative. And I think the practitioners prove that because they bill for sedation to the insurance and to the patient. Otherwise, I think we have some issues with that as far as fraud or something, if they're billing it one way and they're actually calling it something different. The second point, I don't think it's going to have much of an impact on practitioners on what they do. When I teach my classes, ever since I taught at Baylor starting in 1986, we've always taught to have it done in the office. I would say probably better than 95% of my practitioners do it in the office, and they've always felt that that's been a rule because that's what I've taught. Some of them don't, and that's it. I mean, we can only teach as best we can, and people don't follow it. And you've seen some cases that have come through when people don't follow what we have. So those are really the two main things, other than also that the pre-sedation checklist is important. And if it isn't labeled as level 1, does that throw that out? I appreciate your time and thank you very much.
Thank you, Dr. Canfield. Committee members, any questions for Dr. Canfield? Saying none. Thank you, Dr. Canfield. We appreciate your participation in this.
Thank you.
Other public comments? Ms. Nichols?
She was on that she left.
That was it. That's the last one. The other person signed up is electing not to speak. Thank you.
Diane decided not to participate.
Well, you had to call her out. No, yes. Yes, she submitted TDA submitted public comment, written public comment, which you can refer to.
I know, but she spoke at the last committee meeting and spoke on this rule, and I wanted to make sure she had the opportunity to speak again.
She has declined your offer. Thank you.
Scoot her off, Henderson.
Thank you, Dr. Yu. Do we have any announcement, committee members? I want to thank Dr. Bell for her report, and it's really good, and I hope you all take some time to actually look into that. I want to thank my committee for participation in this rulemaking and challenge, and I want to thank Dr. Tillman for his dedication and service to the state board as his last opportunity for me to chair to recognize him and his service to the state of Texas. So thank you, Dr. Tillman.
I may be around a little bit longer, but this committee is just an example of the process working, a variety of opinions coming forward with informed knowledge to have exercise significant discussion and work for the public safety of the state. So it's been great. And I'll be here until our governor says otherwise. Thank you.
Thank you, Dr. Tillman. Committee members? Thank you, Dr. McNeil.
Thank you.
Just to add on what Dr. Tillman said, this group has certainly had to deal with some heady issues over the past couple of years, and a lot of things that we had to do based on a variety of things, and we could disagree at times without being disagreeable. And I very much appreciate that.
I like that sentiment as well. We all have different opinions and different biases and different backgrounds. And the bottom line is we're here to protect the public. Any other committee members? And how about a motion to adjourn? That's what I'm looking for. Dr. Tillman.
Yes, so moved.
Motion to adjourn. Do we have a second? Dr. Yu? All in favor, raise your hand. Motion carries unanimously. It is 3:20 p.m. Thank you.
See you tomorrow.
Thank you, guys.
Bye-bye.
Anyone on for disciplinary, just please mute yourself until we get started at 3:30. Thank you.
10 minutes.
Hi, Dr. McNeil.
Okay, are we ready to begin?
Yes, let's see if your committee is all here.
Ms. Sisk reached out to me and said she will be absent.
Yes, okay, then you're good. You have your committee.
Fantastic. Well, I would now like to call the March 11th, 2021 Disciplinary Review Committee meeting of the Texas State Board of Dental Examiners to order. The time is now 3:31 p.m. As far as protocol, we're on computers. Please be mindful to mute until it's time for you to speak. Ideally, please say your name during voting. And if you have a comment, the thing that seems to work the best, just kind of raise your hand and I'll try to take note of that. Let's go ahead, and I would like to read off the mission for the Texas State Board of Dental Examiners. And that mission is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and to their patients. At this time, Ms. Nichols, would you like to perform roll call?
Yes, sir. Dr. Robert McNeil.
Present.
Dr. Linda Burke.
Present.
Ms. Lois Palermo.
Present.
Ms. Catherine Sisk is absent. And Dr. David Timlin.
Present.
Thank you, Dr. McNeil. You have a quorum.
Fantastic. Thank you very much. Well, let's move on to item number 3 on the agenda and talking a little bit about hospitalizations, self-reports. I wanted to have a discussion with legal and with Dr. Bell. And part of the reason I wanted to do that is the Advisory Committee on Dental Anesthesia had raised the issue of self-reports and wanting to make sure that we were able to get access to that information and encourage practitioners to self-report various things. And so I've asked Dr. Bell to kind of talk to us a little bit about the process of self-reporting. From my standpoint, as an oral maxillofacial surgeon, we have patients who are unfortunately hospitalized a number of times for a variety of different reasons. And I wanted Dr. Bell just to kind of walk through that process. So Dr. Bell, can I turn it over to you?
Yes, sir. I have included kind of at the 11th hour, but in your materials, you'll find a document titled Self-Report Case Flow. I was making myself notes and thought that they would be useful in your analysis as well. Essentially, we have several different phases of the case flow for self-report cases. They are officially considered complaints within our system. However, they are self-reported by our respondents. The catchphrase within the rule is as a possible consequence of dental treatment. And the rule does imply that the patient really needs to be admitted to the hospital in order to require a self-report. So the cases come in on a special form. Again, they are complaints, but we have a dedicated form for self-reports. We begin in the preliminary investigation. The intake specialist analyzes the case, and then the next person to see it is one of our analysts who is a registered nurse. So both of them analyze the case and see that it is as a possible consequence of dental treatment. Make sure it does meet the criteria set forth in the rule, and look for any other obvious issues of patient safety. If those criteria aren't met, the case is closed at that time. Should those criteria be met, the case is then moved on to an official investigation. Let me back up one step, and this isn't in my notes, but the respondents send in all of their records, typically with their self-report. That's usually the most expedient way for us to handle the case. And again, our registered nurse is, one of the first ones to see those records, and she's able to go through those and analyze them. So we moved on to the official investigation. Sometimes we still have some records to get, especially from the hospitals. That can take a little bit longer. Sometimes we receive all the records before the preliminary investigation ends. Again, they're evaluating the records. They're referring back to that criteria of the rule. Cases can certainly be recommended for closure at that point. All closures of that nature need to be approved by either the dental director or the director of investigations. So should the case continue to make it down the line, we would prepare the case for DRP. In the documents that go to DRP for their review, there's a note that reads, please determine if the patient's hospitalization was a result of a failure to meet standard of care by the respondent. Please attempt to limit your case review to the treatment or event relative to the self-report. However, if patient safety is a concern, please cite any applicable violations. So both in the training as well as in specific directions prior to the review of the case, that's the guidance that we're providing DRP. And again, specifically when speaking of their report, the way that I've trained them is to be sportsmanlike. Recognize that this is a voluntary submission of an adverse event. And again, try to limit your review to issues surrounding the crucial event of the self-report. Again, if patient safety is in question, we don't ask them to turn a blind eye. But that is the general guidance provided. I made a little note in your materials that should y'all come upon a report you feel focused on issues not relative to that initial self-report, the event surrounding the self-report, then please use that feedback form, and that way we can analyze that case, and then that will inform training. So once the DRP report is written, the case is then evaluated by either both myself and our registered dental hygienist that works within my division, or one or the other. So if there are no violations found, the case is closed. If there are violations found, the case may either be recommended for the pre-ISC evaluation that you all are familiar with, or the case may be recommended to be set for an ISC date. Again, further guidance from the board members regarding what would need to be put in the pre-ISC bucket and what would need to be put in the set for ISC bucket would be welcomed. So that takes you through the process. Until we get to DRP, even right before DRP, we definitely look to see that the case meets the criteria set forth in the guidance, the rule. And but again, that takes you pretty much all the way through spots that we are able to close a case, and then the reasons why it would keep moving forward.
Dr. Tillman, did you have a question for Dr. Bell?
Can I review, it's kind of basic question, but could I review the definition of hospital, the definition of admission? With the recent years, there's been just an increase in these emergency centers and the utilization of those. Does that, adhere to an admission or a hospital admission if the patient goes to, say, a doc in a box or one of the emergency centers?
And I know we've sort of had that discussion before, and I can't remember. I think it was both on the anesthesia committee and perhaps this committee. And I think the consensus that we had come up to is if it is in a hospital and they're evaluated in an emergency department, sometimes they'll even just be entered into the hospital for a 23-hour admission, or sorry, an observational status before a full admit. Part of that is, I think, a medical insurance billing issue, but part of it's also just the severity of care that's needed would be the issue. Sorry, I had a little thing going on there. So that is my delineation, I think. And legal, please correct me if I'm wrong on that. Now, it may mean that you're at a hospital under a 23-hour observational status, and you actually may be there 25 hours because they've been trying to discharge you for a couple hours. But that would still technically be a 23-hour observational status. And if it's a more complex type of case, then certainly you would get a full admit to the hospital. Am I wrong in my thinking there, legal, or are we all on the same page there?
We're on the same page.
Okay.
I
Dr.
just
Tillman,
want-
does that answer your question?
Yeah, I just wanted to review that because I know that there have been some questions that I've had. And as much clarification as we can continue to give to our clinicians is helpful. Thank you.
And I'm glad you brought that point up, Dr. Tillman. That was part of the ACDA report that they had put out in 2020. Was they wanted some specific clarification, I believe, on what does constitute a hospitalization. Is that something that we need to put it out in the newsletter? Is that a major enough issue that we feel from the legal side of the equation, or is that pretty easy for you to tease out and elicit?
I think that's, the more information, the better, right? So that's very easy to add to our newsletter, and I'll be happy to include that in the next round.
Okay, why don't we do that, and then I'll figure out, or you can figure out who, if you want someone to take a look at that as well, and just make sure that that's our consensus. Any other specific comments from any of the committee members or questions for Dr. Bell or dealing with hospitalization? Okay, one of the lines here, oh, Ms. Studer?
Dr. McNeil, just to clarify, so then inpatient admission, would that be 24 hours?
So we get a little bit away on the timeline. And I think part of this is just the way the hospital system is set up. And a lot of that is the way it's set up from a billing perspective. And so if a hospital is going to send out charges, they get a different medical code and a different fee if it's a 23-hour observation versus a full admit. When I have a patient, I take them to the operating room, I have to tell them kind of beforehand, okay, the patient's only going to be there for 23 hours. That just means I'm doing the procedure. Now, technically, it's probably going to be around 23 hours, but it's how we sort of classify it from a billing standpoint. And if I need to fully admit the patient, say there's a complication during a procedure or their condition worsens, then we technically have to ask for a full admit. And once again, it's on the medical coding side of the equation, but it also usually will deal with severity of the patient's condition. And that's where I think it's appropriate here as we're looking at things from a board perspective. You know, if a patient has to be fully hospitalized, and that may mean a day, 2 days, 5 days, whatever, that's a more significant event, as opposed to they go to the ER, they had some post-operative bleeding, they were evaluated by the physician, they stayed in the ER for X number of hours, which may in fact be 20 or so, or it may be, I hate to say 24, but it may be 24, but it would not be a full admit to the hospital. And I think if it's a severe problem, then it is a full admit, and that's when we would want to know about it from a self-report. So I think our rules are good, but maybe we just need to help with some clarification to clear that up for people. The other factor in that report that I was referencing from the anesthesia group, and I did have the line here, they were basically asking us to try to find a way that if someone did create a self-report, let's see, the ACDA also recommends board staff create a mechanism in the proposed expanded self-report rule that does not allow disciplinary action to occur in order to encourage dentists to report adverse events. So that's a line from that report. Personally, when I read that, it's difficult to say, okay, you have a negative outcome, you self-report, there's going to be no disciplinary action. And that's sort of why I reached out to Dr. Bell to see what the current process is. And I liked the term you used, and now it's escaping my brain, Dr. Bell. Was it sportsmanlike, or is that the term? Okay. So let's get something out in the newsletter. More information's always better, especially with something like this. Okay. Any further comments, Dr. Bell, or any questions for Dr. Bell? Terrific. Well, we appreciate. Oh, Ms. Palermo.
I have just a comment. So does outpatient not come into play with this at all? When you were talking about the 23-hour observation?
So a lot of times, so if you're having a procedure done and it's an outpatient procedure, I believe a lot of times it will be coded as a 23-hour observation. So if I do an outpatient, and now if it's in an outpatient facility, it's a surgery center offsite from a hospital, that's not going to be prepared to do a full admit. If it's a doc in the box, like Dr. Tillman kind of referenced, they're not going to be able to admit the patient fully. And we don't want to get trapped up a little bit in the length of time from an hour's standpoint, because a lot of factors can come into play. You're waiting for your ride home to be discharged and you're there 27 hours. Well, the hospital is only going to be able to bill for a 23-hour observational status. And it's just other things kept you there numerically past 23 hours. Dr. Tillman, comment there?
And I appreciate the increased communication through the newsletter. I would also suggest that there be a review of this specific item with DRP to make sure that self-reports are indeed a requirement, that they meet those parameters that are a requirement of the self-report. Because from my experience, I think some of those self-reports really may not have met the definition of a required self-report. So that would be my other recommendation. Thank you.
So then a question to the committee on that very point, should that be, as we look at the information flow or the decision tree there with Dr. Bell that you provided, is that something on the front end before it goes to DRP, that we look at something and say, okay, this doesn't meet criteria for self-report, you self-reported this and technically you should not have? Or is it difficult to tease that information out until the chart's fully reviewed by a DRP member? Dr. Bell.
I believe that, again, we have a registered nurse reviewing the records from the beginning. And I believe that we identify the majority of those cases. However, we also, in the interest of public safety, try to just use common sense as well. If there's a case that may not, because they are considered complaints, although it's a self-reported complaint, we try to find that balance of not moving forward with those that don't meet the criteria. But again, if it's 23, 24, if the language is a little different for various hospitals and the issue is quite serious, perhaps oversedation, perhaps respondent not available, or lack of care could even be a situation. We try to use common sense while following the guidance of the rule. If my my RN is very logical, and should you disseminate the guidance that you do not want to see any case that did not get fully 100% admitted to the hospital, then I can provide that guidance to her and you wouldn't see any more. But at this time, we do try to find a balance using common sense, since it is technically a complaint and it is already in our hands and our charge is public safety. We just try to balance all of that.
So let me do this sort of scenario. Let's say a patient has a tooth extracted. They go to a doc in the box, a standalone care facility, and they're there for post-operative bleeding, and they're there for a couple hours. Bleeding stops. They get sent home. The dentist does a self-report. What would you do in a situation like that? Would you kick it to DRP?
I do not believe in our current practice that case would ever make it to DRP.
Okay.
That is not my intention.
In one of my, from hearing from stakeholders in the past with self-reports, there was always a concern that if a patient does get admitted to the hospital necessitating a self-report, it was for a condition that was outside of what was performed, but they did still do a self-report, and there were a minor records violation. Radiographs didn't have an interpretation, for instance, that, did we want to see a disciplinary action based on something like that? And what I hear you saying is you're really telling the DRP people to focus specifically on the hospitalization and what was the causation of that. Is that correct, Dr. Bell?
Yes, sir. That is the current guidance. Again, that general sportsmanlike guidance. We don't want to go fishing. We want to be fair. Now, I would not ask any of my DRP to turn a blind eye to something involving patient safety. But outside of that guidance, yes, sir, we really want them to focus on the matter that required them to be admitted to the hospital and give us their opinion on standard of care relative to that matter.
Okay, terrific. We'll see no further questions for Dr. Bell and no further comments on this issue. Let's move on to item number 4 on the agenda. Item number 4 is talking about Texas Administration Code 108.57, sort of dealing in the area of false, misleading, or deceptive advertising. We kind of put that out there. I wanted to start a discussion within our committee here to try to be proactive on some issues if it is an issue. Specifically, we are a complaint generated agency, and with social media, what it is, there is an opportunity to have a incredible number of complaints on a specific issue. And I wanted to know sort of how we plan on sort of moving forward as an agency if we end up having, let's say there's a respondent who has multiple complaints about a similar issue. Are those all going to be grouped together, for instance, into one complaint? And part of it is I'm trying to make sure we're having appropriate utilization of legal staff. So I'm going to push that off to, I don't know if Ms. Nichols or Ms. Studard would like to start the discussion there.
Sure, I don't mind jumping in. So Dr. Bell and I, we had a discussion about this yesterday, and it's my understanding that when we have a situation where we're getting, say it's a high profile situation and we're getting multiple complaints, they'll obviously try to narrow it down to the key issues that are going on in the situation. And then obviously every complaint that comes in is reviewed, but it's not going to be a situation where the practitioner has 20 complaints, 20 case numbers against them. We'll narrow it down to, like I said, the key issues going on. I get that right, Dr. Bell?
Okay. Dr. Bell, did you have anything to add to that?
I would say that sometimes, because of, again, how we're required to handle complaints via statute and rule, sometimes, I had staff do a quick query, and there was one situation that had 44 complaints. It is my understanding that we still have to get those into our system, and they would get a case number, because that is the requirements of the statute and rules. However, that would just be one investigation. The only time that would be spent would be to fulfill the obligation of every complaint in writing. We're obligated to process that fulfills the requirements in the complaint. So it would be my understanding that there may be multiple, but there would not be, the same person would get assigned all of those. Should the investigation be pretty much completed and more complaints on the exact same issue come in, we would not normally, unless there are new issues that come to light, we normally wouldn't do any additional investigation. They would just be deferred to the final disposition of the case that had already been heard. And hopefully that makes sense. But again, I'm happy to change direction to staff based on the flexibility we have within our rules and statute.
So what I hear you saying is one investigation with multiple complaints on the same issue, but separate individual case numbers per each individual complainant?
Yes, sir. At this time, that is how we operate, to my understanding.
And, the challenge is, say, for instance, we have 100 complaints on one social media post, for instance. That's going to distort our case numbers in a pretty significant way if we're just looking at trends, for instance, unless we isolate them as specific to advertising or social media. Does anyone share that concern on the committee?
Yeah. I agree, Dr. McNeil. We're in a new age where, in the blink of an eye, an advertisement can go out, a banner ad, Facebook, and go to hundreds of people. It just is a new age, particularly with advertising, which is kind of what we're talking about. And so one small statement that might be misleading to some, or under our rule, definitely misleading, it can have a significant impact. So I think we're in a new age with advertising, and I think we need to kind of try to be ahead of what's happening. Thank you.
Any other comments from committee members? Ms. Palermo?
I did have one little question as I was looking through the rule, and it made me think that, are there the word painless? Are they never allowed to use that in advertising in any way? Is that the kinds of things that we're looking for?
I think that's part of that rule breakdown. Painless, I think superiority, there's a full list there, and I'm glad that y'all were kind of forwarded the rules that we have there. There's also the additional rule in a different section just under the general provisions, I think, is just unprofessional conduct, for instance, which unfortunately is a very broad term. Dr. Bell.
So just to be clear, regarding advertising complaints specifically, the vast majority, if not all of those, would receive a cure letter. The investigation normally doesn't go much past intake. So the intake kind of serves as the investigator and will, like I said, issue a cure letter indicating how that advertisement doesn't meet our rules. And then the case is closed there. So we don't invest a ton of staff time, whether we get one complaint on an issue or 50, it's a very similar amount of staff time. And again, the majority of those are resolved with a letter.
In the cure letter, just for a point of information, is that basically you reach out to the respondent, you say, we've had this complaint, this is the concern about your specific advertisement that you've posted. It goes against our rules. We asked you to take it down, and then it's solved. Is that what you mean?
I would lean or look to Ms. Studdard to answer that question. I have only for a short time been the director of investigations, and I haven't changed any of the existing processes. So the specifics of that cure letter, I couldn't speak to without a little more research. So I would look to Ms. Studdard to answer that question.
That's the gist of it. I haven't seen a cure letter in a while either, but the gist of it is sending a letter to the dentist saying that we received this complaint. If there's a violation, here's the rule that you're violating it. And we give them a specific amount of time to change their advertisement.
So what are most of the complaints on in advertising? What area?
I guess that's a question for legal and Dr. Bell.
Isn't it usually, isn't it usually a specialty that a lot of times we see that it being a specialty that we don't actually, implantology or something like that, where it's not actually a specialty, or something being free when it's not free. That sort of thing.
Okay.
Well, and we may be a little on the front end of this, and with social media, as Dr. Tillman said, one of my classes right now for my MBA is dealing with health information management technology, and social media can be your best friend or your worst enemy. And I just don't want the agency to be inundated with a situation that may happen without sort of having a mechanism in place to sort of deal appropriately with the issue, but not bog the agency down. And we don't want our caseload data sets being skewed heavily by one complaint that generated 50 to 100 to, the way social media works, obviously you can run into the thousands pretty darn quickly. And what I hear you saying is that that's not happening right now. And it may just be something that we have to be mindful of if it does pop up. Any other questions, concerns from anyone? I see Dr. Bell, and then any committee members after Dr. Bell makes a statement.
Two things. The case with 44 complaints, that was actually a patient abandonment issue where folks were not able to get their records. More often than not, we will receive a pretty good chunk of emails that don't necessarily have a full complaint attached that is filled out appropriately. So, we might get 30 emails, but only 10 complaints on the issue. So to this point, we haven't really seen that situation with actual complaints that we have to manage. But again, for the most part, it just adds to the workload of the very first person that has to put that into our computer systems. I understand your concerns regarding skewing numbers. However, it's just that first person, and everyone else handles that as one.
Terrific. Any other comments before we move off this discussion? Okay, thank you, Dr. Bell, and thank you, legal team, and thank you, committee, for that. Let's move on to agenda item number 5. We're going to talk about the AAP and cases resolved prior to the ISC process. And, I'd love to thank our committee. We've gone through the disciplinary matrix review and set up some mechanisms in place as far as AAPs, the administrative penalties as an option in the toolbox. We have tried to do our best at setting up a mechanism for pre-ISC dismissal. And what we're trying to do is really be an efficient use of resources for the agency, have more time and effort to deal with some of the more serious issues and unclog some of that ISC caseload So I don't know who from legal, if it's Ms. Camp that's going to take the baton on this one to start this discussion. Is it Ms. Camp?
I can start it, Dr. McNeil.
Oh, Ms. Studdard.
Did you just want a general overview of how it's working? Or?
Let us know how it's going. Yes, just because this committee's been pretty involved with all of that and how it's going, and do you wish things could be modified in a certain fashion, that sort of thing.
I think it's going very smoothly. I think, like you said, it is unclogging the cases. The less egregious cases, we can push to the pre-ISC process and keep our ISCs full of cases that are more egregious. And so pre-ISC process, it's kind of broken down into two separate areas: standard of care cases versus non-standard of care cases. Our standard of care cases, of course, are seen by a board member, and they review the DRP report. They review a memo from the staff attorney detailing the facts of the case, and then the board member decides whether the case should be dismissed. Some other action should be taken, like an remedial plan should be proposed, or an agreed administrative penalty should be proposed, or the case should go to an ISC. The second kind of chunk of cases we see are non-standard of care cases, and those cases are reviewed by staff attorneys. After looking at the facts of the case, the matrix board rules, they'll propose a resolution for the case, whether it be dismissal because there's no evidence or it doesn't rise to the level of disciplinary action, or they'll propose some type of public action to the respondent, such as a remedial plan or agreed administrative penalty. If the respondent refuses to sign the remedial plan or agreed administrative penalty, they have the option to go to an ISC to appear before a panel. So it has been working very smoothly on our end.
Dr. Tillman?
So I totally agree. I think that even though it's a new system, relatively, I think it's been, particularly with the pre-ISC format of it, is going well. I like the addition of that additional step to kind of unclog things. To me, if there's any confusion at all, it's between the remedial plan and the AAP. Not confusion on what it is. I think we get clear guidance from legal counsel, but which type of cases are more appropriate for the AAP as opposed to a remedial plan. And I tend to grab remedial plan. I think it's a good, get out of jail card, but others will feel like AAP is a better option. And I just want to know those kind of nuanced differences between the two cases, if I could.
That's a terrific question. Ms. Studer?
Staff usually recommends if a remedial plan has already been offered in the case, but the conduct doesn't quite rise to the level of a board order, the board has the option to offer an agreed administrative penalty. So it's just another tool in the toolbox for the board to use, where a remedial plan has already been offered. It doesn't quite rise to the level of a board order. So instead, the board can issue an agreed administrative penalty.
Okay.
I think one of the things that we had talked about early on with this committee was having some mechanism in place. We all wanted to be able to give a fine that was not going to be reportable. We didn't want to dismiss a case if rules weren't followed. We wanted to give a financial penalty. So the respondent was aware and got a little slap on the wrist, but we didn't want something to show up as public record. That was not a possibility due to the way statute ran, that if we do any sort of thing other than a dismissal, then that's a action that is on our website, and remedial plans, are classified as a non-disciplinary mechanism, but really it's on the website, and you pull up and search the practitioner. So, okay, it says non-disciplinary, and we were trying to get a carrot that would kind of help out here. At one point, we had talked about trying to get AAPs on a separate portion of the licensee search. I don't know if it was an IT issue with that. Basically, where I'm going with this conversation, we wanted AAPs, the agreed administrative penalties, to be something that respondents would say, yes, this makes sense for me, and their legal counsel would say, yes, this makes sense for you. But we weren't, it seems as though we're still working that process. Comments on that? Ms. Camp, I see your hand up.
I would say, just from a practical standpoint, from legal, and then just our attorneys, especially reviewing those non-SOC cases, you're going to have a lot of counsel, opposing counsel, that's going to want that remedial plan if their client has not had any sort of issues with the board before. Even if it's not necessarily a standard of care issue, say it's more administrative, right? Which the AAPs are such a great tool for us to have whenever it's a strictly administrative issue. Say, for instance, lapse in your licensure, or not providing, or having your BLS or PALS or anything like that up to date. It's a great tool to have for that. However, you don't have any disciplinary history, and I'm really glad to see that so many of our licensees really care about their licenses and about their reputations and want to really uphold our rules and our standards. So it is very important to them not to have disciplinary action. I can appreciate that. That said, I think the overarching trend right now, at least from legal, especially pre-ISC, is to offer a remedial plan if one has not been given. That's not every case, but the remedial plan will be issued, and then of course the AAPs do become a lot easier to swallow once that remedial plan has been used. And I would say we have a really good defense bar here that has done a great job of educating their clients that, in the scheme of disciplinary actions for the board, that it is within their best interest to take versus, fighting it up the ladder if there is really an issue that is disciplinary worthy.
So a point of clarification here, both the non-disciplinary remedial plan and an agreed administrative penalty, the AAP, neither of those are reported to the National Practitioner Data Bank, correct? Okay. Do any of the committee members feel a strong need or desire to see if IT has the ability to isolate AAPs on a different portion of the licensee search to try to make this a better carrot, or we just don't think we need to go there? Because I don't think AAPs are working out quite as we had perhaps initially envisioned them to work. Anyone want to make a comment about that?
Well, I was trying to figure out, I was thinking you were going to use the AAP in two different ways, possibly. One, if they hadn't had a remedial plan, or if they had a remedial plan, could you then give them an AAP? So they could go either way with that. But you're talking about strictly before an ISC, right?
Ideally, yes.
To be clear as well, a remedial plan is not a requirement in order to get to that AAP level, right? Just in practicality, that's kind of how these things have worked out. Not every situation, but it has worked out that if there's a remedial plan available, even though the AAP is on the table, a lot of times that will be the recommended disciplinary action. But you are absolutely right, Ms. Palermo, pre-ISC, post-ISC, in either of those situations, an AAP can always be the recommendation to resolve the complaint, regardless of whether there's a remedial plan currently on file or not. It's just more of a practicality issue than a requirement within our rules and statutes.
So who is doing the pre-ISCs with the AAPs or remedial plans?
I review pre-ISCs, and it's up to me. There are several categories where I either feel like it needs to go to an ISC or can be resolved either with no action or an AP or whatever.
It depends. That is certainly one area, or one way that we utilize these, what Dr. Tillman was referring to, our attorneys will draft pre-ISC memos and include a TRP report, sometimes an investigative report, so that our panelists that are here for ISCs, that's usually who reviews them, it's whoever's here for an ISC at the time, they'll have something to kind of base and look at and see what our reviewer has come up with as far as violations go, have a little bit more context for it. That's one way in which things are utilized pre-ISC that has a board member review. What Lauren was discussing earlier was that bucket of non-SOC cases in which I typically assign them out to our attorneys for review, and there is ability for us within statute to make a determination as far as what the appropriate action would be. So sometimes the attorney will recommend a remedial plan or an agreed administrative penalty to resolve the case without having that the mechanism of a board member reviewing a pre-ISC memo. It's largely used in non-standard of care cases in which it's a fairly clear issue of violating an administrative rule that we as lay people, as far as not being dentists, can analyze and say that yes, there's a violation of the rules.
So do you keep a record of the number of those that are done? And are they included in with the rest of how many remedial plans we've done and how many cases we've solved? Well, I guess it really would, is it a case at that point in time?
Ms. Palermo, you can look at our legal report. We have those numbers for you.
That's what I was wondering. Okay.
And Ms. Palermo, in our board packet, we have the pre-ISC and the post-ISC dismissals there as well, and you can sort of go through that, and that gives a general flavor. You know, we really wanted to unclog that coming down to Austin with your attorney and, you know, for the appropriate sort of clinically concerning patient safety events for sure. So I hear no one on the committee is real excited about trying to make AAPs a little more of a carrot, or we just continue moving forward. Dr. Burke.
Yes, Dr. McNeil, I just want to make sure I understand correctly, because I think I'm a little bit confused. So what your question to us is, do we feel that IT should work on making the AAP a little bit more visible on our website? Like if somebody's looked up, I mean, a dentist is researched or looked up, I'm confused. Because what is it that we want IT to accomplish?
So our initial talk that was brought up, I think it was actually by Dr. Haynes, perhaps, some time ago when we initially started talking about AAPs, was having a separate section on the licensee search for the AAPs. The way I envision this, if you have a complaint filed against you, you don't have vitals on a patient, that's the only standard of care violation. There was no negative clinical outcome. At some point, we've looked at that as such a minor issue that we dismissed it. Other times we'd look at it and say, okay, well, you didn't take vitals on this patient. There was no negative clinical outcome, but you still didn't follow the rules. We're going to give you a AAP fine, or we're going to give a remedial plan with 3 hours and records and risk management, for instance. I just wanted something that was going to be palatable and was a little more desirable. But
right.
maybe the process.
Right now, where is that AAP listed? Is it listed anywhere? It is. And so we're trying to make it more attractive for the respondent to accept the AAP and keep them out of the ISC. Well, I would think that would be beneficial, Dr. McNeil, to answer your question. I mean, that's what, but I hate to put a lot of work on our IT. I mean, if that's something that's difficult to accomplish, I mean, I don't know if we'll benefit much from that.
So a question to legal, is the remedial plan / AAP system working well and not broken and we should keep our hands off it? Or do we want to think about a modification?
Legal it's working fine for legal. Agreed.
Okay, I personally think if it's working fine, and I'm sorry, Dr. McNeil, I'm speaking out of turn, then I would say I would prefer to leave it as is if there's not an issue or a problem at this time.
Okay. Any other comments from anyone else? Okay, seeing none. Well, thank you for, it's certainly a group effort with this and what y'all are able to do, getting us the info pre-ISC. You know, we want to unclog a system. We want to keep things moving in an efficient way. That's best for the public. That's best for our licensees / respondents, best for the agency. So thanks y'all for being a part of that. Let's move on to item number 6 on the agenda, public comments. Do we have any public comments?
We do not.
Okay. Seeing no public comments, I do not have any announcements. We did not meet last time just because I felt y'all had done such a great job. We didn't really have a whole lot of issues to discuss and didn't want to have a meeting just to have a meeting. And we've done a lot of work. The disciplinary matrix was a big deal with multi moving parts here, and everyone participated in it. That's terrific. So any other committee members, legal, any announcements from anyone? Okay, hearing none. Do I hear a motion to adjourn? Ms. Palermo, second by Dr. Burke. All in favor, raise your hand and say aye.
Aye.
Terrific. I call the meeting to close, 4:22 p.m. Thank you all.
Thank you. See you
Thank you.
tomorrow.
Bye-bye.